Good morning, sir.
Hi, good morning.
Yes, sir. Your audio is good, sir. You can share and see once you want to share.
Yeah, I'm sharing my screen right now.
Yes, sir. All is good over here.
Yep.
Okay, sir. We'll start in 5 minutes, sir.
Yeah, I'm ready.
Yes, sir. I'll let you know, sir. 5 minutes, please. Thank you.
Hi.
Good afternoon, everyone. Uh, I request you all to kindly settle down. We'll be beginning our session in 5 minutes' time.
Recording in progress. Recording stopped. Recording in progress. Recording stopped.
Good afternoon, everyone. Firstly, wish you all a very happy Independence Day and welcome to Telederm India 2025. It's a great honor to welcome you all to the workshop, Dermatopathology Made Easy. We are privileged to have with us today chairing this session, Professor Dr. Jayaka Thomas, Sir, Director, Department of DVL, Chettinad Hospital and Research Institute. Sir has many publications in various national and international journals to his name. He has also received many prestigious awards over the years. This session is co-chaired by Dr. Dawn Ambrose Ma'am, who is a consultant dermatologist at Pantai Hospital, Kuala Lumpur, and Central Dermatology Specialist Clinic at Nexus, Bangsar South, Kuala Lumpur. I request Ma'am and Sir to take the session forward. Sir, please.
Thank you very much, Dr. Srisha, for those words of introduction and for calling me here. Of course, I have the great pleasure of having Dr. Dawn Ambrose with me to join me. Please come up. I have to tell you that we had to start a session this way. We had huge plans for Dr. Rajendra Singh. 6 hours of dermatopathology was something wonderful to listen to, but we are still going to listen to Dr. Rajendra Singh for 6 hours. And if you look at his CV, it's up there. It doesn't make much sense for me to read out what's there already. But however, we must tell that he's been a very close friend of the Indian Society of Teledermatology, apart from being a family friend to me. He's got a lot of accolades and lots of degrees, and most importantly, he runs what is known as a Path Presenter, which made us all learn dermatopathology well. I don't know how long I've been knowing Raj. I call him Raj. He's a very familiar person to me. Several years I've known him, but I don't know how I came to meet him and how I got to know him. But I know him very closely, and we are good friends, family friends too. And with these words, I would request Professor Rajendra Singh to take center stage, and also request Dr. Dawn Ambrose to join me in chairing the session. Wish you all a very good afternoon and wish you a great enthusiastic dermatopathology session. I just got introduced to a pathologist now. A pathologist coming for a dermatology conference, something which means a lot to people like me who are heading the society on. Thank you very much to all of you. Enjoy your afternoon.
Should I go ahead and start? Okay. So thank you, Dr. Thomas, for the invitation and the kind introduction. I'm sorry I couldn't be there, but there were some flight issues and things didn't go well, and I had to come back home. The flight did not even take off, and my baggage is still stuck at the airport. I still haven't gotten my baggage back actually. So without much ado, because we have a long session, I'm going to start off with the session. So we are trying to do a lot of a complete review of dermatopathology, and this is going to take a lot of time. So thank you for coming for this long session, and we'll try to at least cover most of the common cases that you would normally see if you are going to practice dermatopathology, or as a dermatologist if you're going to see a lot of patients. So hopefully you can see my screen well. Okay.
Yes, Dr. Raj.
Okay. Thank you very much. So we have 100 cases here. So I'm going to very quickly start off with case number 1, which we presented as a 35-year-old male, and they had these silvery scales on their elbows and knees. So here is the biopsy of that patient. So whenever in dermatopathology, it is always very important to look at the features on the slide rather than trying to jump to diagnosis at the first attempt. Because if you are a pathologist, you have to understand that clinicians and dermatologists are very well trained to read dermatopathology reports. And many times it is very difficult to pigeonhole every case into one diagnosis. So if you cannot come to one diagnosis, it is okay if you can give a list of differential diagnosis. The clinician is very, very smart enough to like look at the differential diagnosis and then see the patient and then make up their mind of what the actual diagnosis is. So that is I think the first lesson that we always teach our residents and fellows, that when it comes to inflammatory dermatopathology, don't try to pigeonhole every case into a diagnosis. If you can do it, well and good, but if you can give a good description and if you can give a good differential diagnosis, you have done your job. And also like to always start from the top to the bottom. So if you start from the top to the bottom, we can see that there's a confluent kind of parakeratosis in the superficial part of the epidermis. And by parakeratosis, what we mean is the retention of this nuclei within the stratum corneum. So you can see like there's a confluent kind of parakeratosis in the stratum corneum, and then below is the granular layer, which is almost absent in this case. So you can see like you don't see any kind of granules here. Focally you might see some, like some granules might be available here, but most of the cases there is like loss of granular layer there. The epidermis shows a little bit of acanthosis, which is thickening of the epidermis, with this bulbous rete ridges. Like you can see all these bulbous rete ridges, and this bulbous rete ridges is what gives it the name psoriasiform hyperplasia. So this is known as a psoriasiform hyperplasia, which yes can be associated with psoriasis but can also be associated with multiple other conditions. So doesn't every psoriasis, like every psoriasiform hyperplasia does not equate to psoriasis. So you have the
Recording
psoriasiform
in progress.
You have the psoriasiform hyperplasia here. And then the most important feature to look for is when you look at the stratum corneum again and you see this parakeratosis. If you scan this parakeratosis focally, you're going to see scattered neutrophilic microabscesses, like microabscesses that are composed of neutrophils. And that is a very important feature to look for whenever you want to make the diagnosis of psoriasis. So you have the confluent parakeratosis with neutrophilic microabscesses in the stratum corneum. You have the loss of the granular layer. You have the psoriasiform hyperplasia. The other feature that has been described very commonly is thinning of the suprapapillary plates. So suprapapillary, so dermal papillae, these are the dermal papillae that you see here. And then the part of the epidermis above the dermal papillae is the suprapapillary plate. So you can see like many places the suprapapillary plate is quite thickened out. Here it is normal, and here it is quite thinned out actually. So you see thinning of the suprapapillary plates, and within the dermal papillae below that you see increased capillaries. In the epidermis, if you look throughout the epidermis, you might also see some neutrophilic microabscesses, which is a common feature that you might see. And the other thing that you might see is increased mitosis within the epidermis. And the increased mitosis is because the psoriasis in the underlying pathophysiology of psoriasis, the epidermis is proliferating at a much faster rate than normal. And that is the reason you see the scattered mitosis within the epidermis. And then the dermis shows you a superficial perivascular lymphocytic infiltrate. So a combination of all these features should easily make you then make the diagnosis of psoriasis. So confluent parakeratosis, neutrophilic microabscesses in the stratum corneum and sometimes within the epidermis, thinning of the suprapapillary plates, loss of the granular layer, psoriasiform hyperplasia, increased capillaries within the dermal papillae, and then superficial perivascular lymphocytic infiltrate. If you see all these features, then you can say that the biopsy is compatible with the clinical impression of psoriasis. But the one thing to also remember in the practical world is most of the cases of psoriasis are easily diagnosable, and clinicians might not biopsy a case of psoriasis. They will only biopsy the case when the patient is not responding to the treatment, to the regular treatment. So when they want to start with more advanced treatments, they might first want to biopsy, confirm the diagnosis, and then start with the advanced treatments. And so most of the cases that come to the pathologist's desk have already been treated. So many times you will not see the all the classic features. So you might not see the confluent parakeratosis that has been described in books. You might see parakeratosis that is stopping, and then you see the hyperkeratosis. You might not see the psoriasiform regular hyperplasia. But the one important feature that is always needed to be seen to call it compatible with psoriasis is the presence of the neutrophilic microabscesses within the stratum corneum. So if you see that and you don't see all the other textbook features, then you can still say that it is compatible with psoriasis. And also, whenever you see neutrophils, it is always better to do a PAS and make sure that you rule out a fungal infection. And then after that, make a diagnosis of psoriasis. Case 2 was a young adult with a herald patch followed by a generalized rash and a Christmas tree pattern. So here is the biopsy from that patient. So let's make it straight. So again, when we start from the top, we can see like there is mostly basket view hyperkeratosis, but then focally you can see this mounds of parakeratosis. So these are known as mounds of parakeratosis. So you see mounds of parakeratosis in the stratum corneum. The epidermis shows you like a little bit of a spongiosis, which means that there is increased spaces between the keratinocytes. So you can see this increased spaces within the keratinocytes, which is a sign of spongiosis. The dermal epidermal junction looks pretty normal. And then within the dermis, you see the superficial perivascular lymphocytic infiltrate. And then you can also see scattered red cell extravasation. So you can see like focally there is some red cell extravasation within the epidermis. So like these are the mounds of parakeratosis that you see here. You see the spongiosis, you see the red cell extravasation, you can see all these scattered red cells within the dermis with the superficial perivascular lymphocytic infiltrate. So if you see all the combination of these features, the mounds of parakeratosis, mild spongiosis, superficial perivascular lymphocytic infiltrate, maybe sometimes eosinophils, but if you don't see them, it doesn't change the diagnosis. The red cell extravasation, and sometimes you might see a focal dyskeratosis within the epidermis. So a combination of these features with the clinical history should help you make the diagnosis of pityriasis rosea, that this patient most likely has pityriasis rosea, and you can give that diagnosis in the report. Case 3, 35-year-old male with fever, sore throat, lymphadenopathy, skin rash, and the skin rash also involves the palms and the soles. So here you can see like this one biopsy shows a little bit of a combination of the patterns. So here if you start from the top, there is hyperkeratosis here. There's focal parakeratosis here. There is some sort of a psoriasiform hyperplasia here, but it's not like a regular psoriasiform hyperplasia that you normally see, but you still see some bulbous retiridges. But then you also see some very thinned out elongated retiridges. And this is another characteristic feature of this biopsy where you see this thinned out elongated retiridges, and Dr. Elston calls them like sexy retiridges because they're thinned out and like very, very long. And then within the dermis, you see this superficial, like almost like a lichenoid and perivascular infiltrate that is composed of a lot of lymphocytes. And then within the lymphocytes, you also see the scattered plasma cells. So here you can see this is a plasma cell here, where the nucleus is a little bit eccentric, and then there is a little bit of a horseshoe pattern like of the cytoplasm. So you can see like a thick membrane around the cytoplasm here, and then the horseshoe-shaped nucleus, another horseshoe-shaped nucleus, and then this is a plasma cell here. So you see admixed plasma cells within the infiltrate. So there is a kind of a psoriasiform hyperplasia with a dense lichenoid infiltrate, which is also perivascular, going into the mid-dermis, composed predominantly of lymphocytes and admixed plasma cells. And then this very thin and elongated retiridges. So when you see all these patterns and when you see the plasma cells, like the one thing that should always come to your mind is syphilis. So if you think of syphilis, then you need to do a spirochete stain, and the spirochete stain can sometimes then help you find the organism within the infiltrate. If you're a pathologist and you're very suspicious of syphilis and you don't see the spirochete stain, you can still pick up the phone and talk to your clinician and say that you still think that this is syphilis in spite of not seeing the spirochete stain, and they should do a serology like an RPR to like make sure that the patient does not or has syphilis. So they can do the serology from the blood and then see if it is positive or not. And also one thing to remember, sometimes the RPR can come back negative. And if the both the clinician and the pathologist are very confident that this could still be syphilis, then you should pick up the phone and talk to the lab and say like, can you do the RPR with dilutions? Because sometimes it is so high that it might come back as negative from the serology test. And if they like do the test with a diluting the serum, then so it might come back positive. So you have to like make sure that you do all these steps if you're very sure that this patient has syphilis.
Dr.
Case
Rajendra
4, a
Singh, Dr.
30-year-old
Rajendra
female
Singh,
with purple pruritic polygonal papules on the extremities.
Dr. Rajendra Singh.
So now if you look at this biopsy, again, like if you start from the top, there is a kind of a hyperkeratosis on the top, but I don't see any parakeratosis. So there's hyperkeratosis with no parakeratosis. Here you can see that the granular layer is very prominent. So you can see all these granules within the superficial part of the epidermis. So this is the granular layer. So the granular layer is very prominent, so it's quite thick here, and it has this wedge shape here, like it almost has this wedge shape here. So you have this wedge shaped hypergranulosis, what is termed as wedge shaped hypergranulosis. So hyperkeratosis with wedge shaped hypergranulosis, and then you have this very dense lymphocytic infiltrate that is slamming or abutting the epidermis. So you can see like it is almost obscuring the dermal epidermal junction, and that is a very important feature to remember. It is not like a superficial dense perivascular lymphocytic infiltrate, because sometimes people mistake this for a superficial dense perivascular lymphocytic infiltrate. So the important feature here is that it is obscuring the dermal epidermal junction. In some places you don't see a very well demarcated dermal epidermal junction because the lymphocytes are obscuring it. And because the lymphocytes are almost like attacking the epidermis, some of the epidermal keratinocytes, they undergo apoptosis. And when they undergo apoptosis, you can see that these pink cells that you see here, so these are dyskeratotic keratinocytes, which are apoptotic or single cell keratinocytic death. Like when a cell dies, individual cell death is termed as apoptosis. When there is a lot of cell death, then that is termed as necrosis. And individual cell death is termed as apoptosis. So there are multiple names that people give these, but some books are calling it Civate body, some books call it colloid bodies, some books call it apoptosis. You might hear some other names, but they all mean the same thing. They are dyskeratotic keratinocytes. That means they are single keratinocytes that are undergoing apoptosis. And based on the level of the cut, in some of them you are going to see this pycnotic nuclei. So you can see the pycnotic nuclei here. And some of them you're only going to see this very bright color pink cytoplasm. And it depends. So if I keep cutting this, I might see the pycnotic nuclei come up basically. If I keep cutting this, the nuclei might disappear and I might just see the pink cytoplasm. So you can see the scattered dyskeratosis, colloid bodies, Civate bodies at the more close to the basal layer of the epidermis, because the lymphocytes are attacking the epidermal junction, and that is the reason you see this apoptotic keratinocytes or Civate bodies or colloid bodies more near the lower part of the epidermis. And because these are keratinocytes that are undergoing cellular death, they will release pigment, and because they release pigment, that you might also see some pigment incontinence within the dermis. You're going to see the pigment incontinence within the dermis. So if you see a combination of these features where this very dense lymphocytic infiltrate that is abutting or obscuring the dermal epidermal junction, that is known as a lichenoid infiltrate. Clinically, lichenification means different, and histologically lichenification means different. So when you talk about a dense lichenoid infiltrate or a lichenoid dermatitis, what you're talking about is a very dense infiltrate that is in the superficial part of the dermis, which is the papillary dermis, obscuring the dermal epidermal junction. So that then you know that you are dealing with a lichenoid dermatitis. And then if you see these other features which show you the hyperkeratosis, the wedge-shaped hypergranulosis with the dyskeratosis, and then some pigment incontinence, then you know that you are dealing with the case of lichen planus. Again, this history is very important. This is with purple pruritic polygonal papule. So this is multiple lesions. If this came in as rule out basal cell carcinoma, that means it is a single lesion. And if it is a single lesion that shows a very similar histology, then you're going to just call it benign lichenoid keratosis. So very, very similar histology. If it is a single lesion, it's a benign lichenoid keratosis. And if it is a rash, then you call it lichen planus. Case 5, a Hispanic woman reports slow onset of gray-brown macules on the trunk over months without other symptoms. So when we look at this biopsy, let's make it straight here again. And you again start from the top. So in the top, what we see is the basket weave kind of hyperkeratosis. The epidermis is also pretty normal, not too much of changes within the epidermis. I don't see any hypergranulosis or any proliferation or even any spongiosis. There's no psoriasiform hyperplasia, nothing there. So the epidermis looks pretty normal. Then you look at the dermal epidermal junction, also a little bit of a vacuolar change here, but not too much, but there's a little bit of a vacuolar interface change here. And then in the dermis, what we see is this perivascular superficial lymphocytic infiltrate with a lot of pigment incontinence. You can see a lot of melanophages within the dermis, with this melanin pigment scattered throughout the superficial papillary dermis. So when you see all of these, there are two diagnoses, especially in the Indian context. Like one is going to be lichen planus pigmentosis. That can show you a very, very similar histology where you see this very you don't see in the lichen planus, we normally talk about the lichenoid infiltrate, but in lichen planus pigmentosis, sometimes you might not see the lichenoid infiltrate. You might just see the superficial perivascular lymphocytic infiltrate with the pigment incontinence. And the other common diagnosis that is more common in the population that comes from South America is erythema dyschromicum perstans, or what is also termed as ashidermatosis. So ashidermatosis or erythema chromicum is the diagnosis for this one. But in the Indian context, this could also be lichen planus pigmentosis. Case 6 is a 55-year-old woman present with progressive vulvar itching and discomfort. So when we look at this biopsy here, if you have any questions, you can always stop me, and we can definitely if any questions about a specific case, basically.
We are trying to do it, Dr. Rajendra. I think we'll have to get established on that a little bit.
Here, this was a vulvar biopsy. The patient had itching and some sort of a atrophy of the skin. So what do we see here? Basically, we see a little bit of an atrophic epidermis focally, but then within the dermis we see this what is termed as dermal sclerosis. Like you can see, this is termed as dermal sclerosis, where you see this pink hyalinization of the papillary dermis. You can see this very pink hyalinization of the papillary dermis with scattered vessels. And then below the pink hyalinization or sclerosis of the dermis, you see a mild lymphocytic infiltrate here. So sometimes you might see this lymphocytic infiltrate, sometimes you might not. It depends at the stage at which the biopsy was taken. If this was an early lesion, then you are going to see this lymphocytic infiltrate. If it is a late lesion, the lymphocytic infiltrate might go away. But the very characteristic feature that you see here is this atrophy of the epidermis, with the dermal sclerosis that is limited to the papillary dermis. So the papillary dermis is the superficial part of the dermis, and then below that is the reticular dermis. So when you see this, then the diagnosis is very easy, that this is lichen sclerosis at atropicus. So LSCA, that is sometimes how this sometimes it is called, but this is very typical of lichen sclerosis, where you see the sclerosis. And the other term that you might read is hyalinization. So sclerosis or hyalinization of the papillary dermis, and then associated lymphocytic infiltrate that might be there or might not be there. An important diagnosis to make, because some of these cases can then progress to squamous cell carcinoma. 5% of these cases progress to squamous cell carcinoma. So it's an important diagnosis to consider. Case 7 is a young adult present with fatigue, joint pains, and a facial rash that worsens with sun exposure. So when we look at this biopsy here, hello? Okay, sure. So should I'll wait for you to call me basically.
Friends, we are trying to get the two-way communication. It's going to take a little time. I would actually encourage you, if you have any questions, this is the best time to ask them. But he is not available right now because we have cut the link for a brief period. We can try to answer whatever queries you have. Later, once we get back and we are reconnected, your queries can go directly to Dr. Rajendra Singh, but you'll have to use only one microphone. Just put your hand up and I'll pass on the microphone to you guys. Did you get me? Yes or no? I can't hear. Very good. Thank you so much. In the meantime, I have the pleasure of introducing Dr. Dawn Ambrose from Malaysia to you. She just asked me the query. She says, how many of them are trainees here? Please put up your hands. Those who are trainees, please put up your hands. Have you all heard what I'm saying? Those who are trainees, please put up your hands. You're busy talking amongst yourselves. Where will be listening to Dr. Rajendra Singh? If you're not interested, I'll shut down this program and you can be free for the rest of the evening. Are you interested or not? I can't hear. No, I still can't hear. Fantastic. Thank you very much. Dr. Padam Kumar is doing all the work here. The last half an hour he's been saying 2 minutes more, 2 minutes more, 2 minutes more. And very kind of him. He has not increased that. Padam, are we set? 2 minutes more, right, okay. My colleagues and I want all of you to enjoy the conference. And don't be so very serious and enjoy it, but learn a lot of things now. This is the best time for you to learn. You've bunked your classes and you've come here saying that you're going to attend the conference. So make use of it. Actually, I was particularly interested in that case, Dr. Don, where he showed a lot of plasma cells, no? And I was wondering what the plasma cells are doing here. Parimalam, there's a call from Ravi. And I was wondering, so much of a party among the plasma cells, We only want to think of syphilis and nothing else at that point of time. But it would have been nice, for us to discuss it further. And that's why I wanted to ask him a question. But then, other things where you get so much of plasma cells, particularly when you get it over the genitals, one has to be thinking of plasma cell balanitis and plasma cell vulvitis. Actually, we have one of our associate professors who has published a case of plasma cell vulvitis. Can I see her here? Can she put up her hand, please? There she is, yeah. I almost missed seeing her. Very nice. Thank you very much, Sandhya. That was a very nice publication from you. It's a rare case. Have you seen Don? You have seen? Syringocystadenoма
Okay, so
papilliferum. Yeah. We are ready? Dr. Rajendra Singh, can you hear me?
Yep. Yeah, I can hear you. We can start again.
Wonderful. So nice, so nice. Can we all clap hands for me? And one more round of applause for Dr. Rajendra Singh. Thank you very much, Dr. Rajendra.
Thank you, thank.
Please.
Yeah. No,
please.
thanks a lot. Yeah, and like I was listening to what Dr. Thomas was saying. Like, if there's a lot of trainees in the audience, like this, I sometimes I've been training a lot of people for the last 20 years. Like the one important thing that I keep always stressing to everybody that is sitting around the multi-headed scope, whether it's a pathologist or a dermatologist. So if you're a pathologist, then definitely you'll always see these cases during your tenure. So it's important to make sure that you have a very, very good understanding of dermatopathology. But if you are a dermatologist, like this, why is this very important for you? Why is dermatopathology very important to a dermatologist? Because especially when you're practicing in India, like the one thing that many times you don't get a very good diagnosis when you send a biopsy. When you send a biopsy, if it is an inflammatory case, many times you will not get a diagnosis with the biopsy. What you're going to get is a description, because for the pathologist to make a diagnosis for an inflammatory dermatopathology needs a lot of experience and a lot of learning during the tenure. But pathologists are very good at writing a microscopic description about what they see on the slide. And if during your training you train yourself to read that microscopic report very well, and based on the microscopic report, if you can start visualizing what are the changes on the biopsy, then it would be very easy for you to make up your mind what the diagnosis is, and that will help you become a very good dermatologist and a good clinician for your patient. And that is what I keep telling my derm residents also that come to rotation, that the understanding dermatopathology and learning dermatopathology is very, very important for you, because many times you will have to interpret from the microscopic description what the diagnosis is for the patient. You are doing this biopsy to understand what the diagnosis is, and if you don't get the report back with a diagnosis, then you're still stuck back to square one. But if you can read the features that have been described on the slide, and if you understand all those features, then based on that you can make up your mind what the diagnosis is, and then you will be able to treat your patient in a much better way. So if you are a trainee, that is the importance of making sure that within your training period as a dermatologist, you become a very good you have a very good understanding of dermatopathology. So coming back to case 7. So here is the biopsy that was generated from case 7. So here, if we start from the top, we see the hyperkeratosis here. Within the epidermis, we don't see too much changes, but here you can see there is this dyskeratosis within the epidermis. But the more important feature that we see here is when you focus at the dermal epidermal junction. The other feature that we will come back to is this follicular plugging that you see here. So you see the follicular plug here. That is another important feature of this diagnosis. But the more important feature here is this: when you look at this dermal epidermal junction, it's almost like it is moth eaten, like that, and that moth eaten, like somebody has actually chewed up the dermal epidermal junction here. And that is what is termed as a vacuolar interface changes at the dermal epidermal junction. So when you see this vacuolar interface changes, the term is vacuolar interface dermatitis, which is a very specific reaction pattern in dermatopathology. So you see this vacuolar interface dermatitis, and within this vacuoles you might see some scattered lymphocytes, and that is what is termed in histopathology as satellitosis. So you're going to see the satellitosis, which is this associated lymphocytic infiltrate at the dermal epidermal junction. And then within the dermis, what do we see here? So if we go back and low power, within the dermis, we see this perivascular. So you see a little bit of a perivascular, but and also a periadnexal infiltrate. So here is a follicle, and you see the lymphocytic infiltrate is surrounding the follicle. So a combination of these features where you see this follicular plugging, you see the vacuolar interface changes at the dermal epidermal junction, you might see some dyskeratosis associated with a superficial and deep perivascular infiltrate and a periadnexal inflammation. If you see all this combination of features, then most likely you are dealing with a connective tissue disease like lupus. So that is what you should try to figure out. Am I dealing with a connective tissue disease like lupus when you see the vacuolar interface dermatitis associated with periadnexal and perivascular infiltrate? If you do a PA stain, you're going to see a thickened basement membrane. So this basement membrane that separates the epidermis from the dermis, you're going to see a thickened basement membrane. And then many of these cases also show increased mucin within the dermis. So for that you do an Alcian blue or a colloidal iron, which are stains that will highlight the mucin within the dermis. So if you see the mucin within the dermis, then it is still more confirmation that you're dealing with a connective tissue disease like lupus. It could be discoid lupus, it could be subacute lupus, it could be systematic lupus. So based on the clinical features, you can then decide what kind of lupus or connective tissue disease you're dealing with.
Dr. Rajendra.
Case 28.
Dr. Rajendra
Yes.
Singh, please, could we have that histopathology of the slide which you just put, and could you please focus on the follicular plug? Just 2 minutes. I'd like to highlight to all the trainees present here, he told us about a follicular plug. And there's also a keratotic plug. Now, how do you differentiate these two? How do you differentiate these two? Huh? A follicular plug, when you follow it down, you get remnants of a hair follicle or whatever is related to a hair follicle. For instance, you find so much of sebaceous glands which are suppressed and pressed down here. So that's a follicular plugging, and here you don't get that. It's a keratotic plug. When you follow the plug down, you should be able to get a hair follicle or remnants of hair follicle. And with that, and this patchy infiltrate that Professor Rajendra Singh was talking to us about, the diagnosis is right in front of you. For us in India, we straight away make a diagnosis of discoid lupus erythematosus. But of course, Dr. Rajendra Singh is giving us a lot of options, Thank you, Dr. Rajendra Singh. You can proceed.
Yep. Thank you very much. So case 8 was a 23-year-old male with a sudden onset of multiple lesions on hand, feet and arms. And they had this outer, when they talk about this central duskiness with outer halo, that is the targetoid lesion that we normally describe them as. So here, if we look at the biopsy here, you can see the biopsy here. So what we see is a basket weave kind of hyperkeratosis on the top, and the epidermis there's a lot of dyskeratosis here. So let's look at the other part of the biopsy, the skin here. We'll start off with this one. So here you can see there's a lot of dyskeratosis, which we talked about the dyskeratosis in lichen planus, which was the apoptotic keratinocytes. But in this condition, the dyskeratosis is not limited to the lower epidermis. It is throughout the epidermis. So you can also see it in the upper parts of the epidermis. So, and then sometimes it becomes so extensive that it involves almost the entire epidermis. So if I go back here, you can see like the dyskeratosis has become so extensive that it is involving almost the entire epidermis. Some of the epidermis is pretty intact and normal here, but then the dyskeratosis is not only limited to the lower epidermis but is also throughout the epidermis. So the characteristic feature that we see here is the basket weave hyperkeratosis with dyskeratosis that is throughout the entire epidermal layer. So you can see it in the basal layer, you can see it in the superficial part of the here. And then if you look at the dermal epidermal junction, there is a little bit of a nice vacuolar interface change that we talked about in the previous biopsy. Here you can see the vacuolars interface changes at the dermal epidermal junction. So all these moth-eaten appearance at the dermal epidermal junction. And then when you come to the dermis, you see this superficial perivascular lymphocytic infiltrate. You might sometimes see eosinophils if it is associated with some kind of a drug. You might see, but it is not always associated with drugs, so you might not see the eosinophils. But the superficial perivascular lymphocytic infiltrate is quite characteristic. So combination of these features where you see this basket weave hyperkeratosis, and what is the importance of the basket weave hyperkeratosis? It is telling you that like when the skin is reacting, the way the skin reacts is the first this changes into some kind of a hyperkeratosis, so it thickens stratum corneum, and then you also start seeing the parakeratosis because it takes that. So if it is a very acute condition, then this doesn't have the time to go into hyperkeratosis. So the basket weave hyperkeratosis tells you that this was something that happened overnight, very, very quickly. So within a couple of days. So the basket weave hyperkeratosis tells you that this condition developed over a couple of days, and then the scattered dyskeratosis that are in the entire layer of the epidermis with the vacuolar interface changes and the superficial perivascular lymphocytic infiltrate, and with the clinical history of the central duskiness and outer halo, the targetoid lesions, then your diagnosis becomes very easy that this is erythema multiforme. So that is your diagnosis. But you also have to remember similar biopsy might be seen in acute graft versus host disease and can also be seen in a fixed drug eruption. So there are three differential diagnoses here: fixed drug eruption, and these are based on the histology, acute graft versus host disease or erythema multiforme, and then the clinical history should be able to help you make the differentiation. If the patient has some kind of a transplant, then you're dealing with acute graft versus host disease. If the lesion is developing at the same position every time after the patient takes some drug, then it is a fixed drug eruption. And if you see this clinical history that we had, then this is most likely erythema multiforme. And then the next case is the 48-year-old female that has this large skin detachment. So here what is, you see the similar kind of histology here, but now the epidermis is sloughing off. Like the history is telling you that the epidermis has been sloughing off and the patient has the skin detachment here. So if you look at this biopsy here, you see this dyskeratosis is almost causing like a necrosis of the entire epidermis, and because the epidermis is becoming necrotic, it sloughs off and then separates out from the dermis. And many times in the biopsy, all we get is this superficial sloughed off epidermis. You might not see the dermis, but you will see the entire epidermis, and that's an important feature to look for, because your main differential diagnosis when the skin has completely sloughed off and is sent to you as a frozen section or is sent to you as a biopsy is, does the patient have toxic epidermal necrolysis or does the patient have staphylococcal scalded skin syndrome? So those are the two things that the dermatologist is trying to look for, that does my patient have toxic epidermal necrolysis or staphylococcal scalded skin syndrome. So the toxic epidermal necrolysis is a spectrum in the spectrum of erythema multiforme, Stevens-Johnson syndrome and toxic epidermal necrolysis. So when the necrosis becomes too excessive, like when the dyskeratosis is extensive and causes almost like complete necrosis of the epidermis that it sloughs off, then that is toxic epidermal necrolysis. The description should let you help you make the diagnosis: toxic epidermal necrolysis. So the entire epidermis is necrolytic, and that should help you make the diagnosis that when you get an entire layer of the epidermis in the biopsy that is completely necrotic. We will look at a case of staphylococcal scalded skin syndrome and see how you differentiate it on a frozen section between toxic epidermal necrolysis versus staphylococcal scalded skin syndrome. So here is the case of the staphylococcal scalded skin syndrome, where this is a younger patient, 4-year-old boy. Again, there is a lot of widespread peeling of the skin. So now if you look at this case of staphylococcal scalded skin syndrome here, many times when the skin is peeled off and you take a layer of that skin and send it for biopsy, all you are taking is this layer of the stratum corneum. Because in staphylococcal scalded skin syndrome, the layer of the split is at the level of the stratum corneum. The stratum corneum is the superficial part of the epidermis. The superficial part of the epidermis is the stratum corneum. So when in staphylococcal scalded skin syndrome, the organism produces the the toxins that cause separation of the superficial part of the stratum corneum, and because they produce this exfoliation toxin that affects desmoglein 1. Desmoglein 1 is more in the superficial part of the epidermis, and that is the reason the stratum corneum will slough off and you will get the layer of stratum corneum in your biopsy. So sometimes when you get this layer of skin, all you get is stratum corneum. So if you just get stratum corneum in the biopsy in a frozen section, then you are dealing with staphylococcal scalded skin syndrome. And if you get the entire epidermis, necrotic epidermis in your biopsy, then you are dealing with toxic epidermal necrolysis. An important distinction, because the treatment will depend on what the diagnosis is. The stratum in staphylococcal scalded skin syndrome, you see this subcorneal separation of the epidermis, and then if you go high power and if you still have the the rest of this biopsy here, you're going to see the scattered acantholytic keratinocytes within the bulla. So this is now a bulla which is subcorneal, intraepidermal subcorneal bulla, and within the bulla you see this scattered acantholytic keratinocytes. Most of the biopsies of staphylococcal scalded skin syndrome do not show you too much of inflammation. So I don't see too much of inflammation here. If I see a lot of neutrophils here, then histologically I also have to think of bullous impetigo. So if I see a lot of neutrophils within the biopsy in the bulla, then also I have to think of bullous impetigo. Otherwise, your main differential diagnosis is always going to be staphylococcal scalded skin syndrome versus toxic epidermal necrolysis. So 45-year-old male presented with oral ulcers and recently developed flaccid blisters on the chest and the back. So let's look at this biopsy here. So this is another classic case here where what do we see here? Like this is the epidermis is mostly gone here. So like we don't see a lot of epidermis, but what we see is at least some of the basal layer that are still preserved here. So you can see the basal layer that is still stuck to the dermis. So this is now this is like an intraepidermal bulla, because the epidermis is sloughed off from the top. So there is a bulla which is intraepidermal, and when you see an intraepidermal bulla, the first thing like you are seeing here is the basal layer of the epidermis, which is here, is still stuck to the dermis. There is a lot of epidermis here. You can see a lot of epidermis still here, but then focally, then there is only the basal layer that is there basically. And this was previously called as a row of tombstones. Like you can see, like these keratinocytes that are stuck to the basal layer, these were referred to as a row of tombstones basically, and that was very classic for pemphigus vulgaris. So a row of so it's intraepidermal suprabasal bulla. Like the previous bulla was in this one that we saw here, this was an intraepidermal bulla, but this was at the level of it was subcorneal because it was below the stratum corneum. So when you see a intraepidermal bulla, where is the bulla is very important. In this condition, which is the staphylococcal scalded skin syndrome or bullous impetigo, the level of the bulla within the epidermis is at the level of the stratum corneum. So you call it subcorneal bulla. In pemphigus vulgaris, it is suprabasal. So you can see like it's just above the basal layer. So if we go back here, you can see like this is the basal layer of the epidermis. So this is an intraepidermal suprabasal bulla. So when you see that, then you are most likely dealing with pemphigus vulgaris. The other characteristic feature is many of the times if there is a follicle here, it will also involve the follicle. So you can see this acantholysis also within the follicle. And what do we mean by acantholysis is the separation of these keratinocytes and they are floating within the bulla. So you see the single keratinocytes which are known as acantholytic keratinocytes that they are floating within the bulla. So if you do the immunofluorescence test, then you are going to see the interepidermal IgG and C3, which is also known as the fishnet pattern of IgG and C3 within the epidermis. So case 12, 80-year-old woman presented with several weeks of intensely itchy skin and the recent development of large tense blisters. So now we are still in the bulla chapter basically. So here now when we look at the split here, so again there is a split within the epidermis, so what is known as a bulla, but this split is now at the level of the dermal epidermal junction. So the previous two cases, the bulla was within the epidermis. One was at the level of the stratum corneum and one the split was at the level of the basal layer. Here the split is subepidermal. So like this is the epidermis that is intact and then the bulla is at the dermis is separating out from the epidermis. So you have a separation between the epidermis and the dermis. So it is known as a subepidermal bulla. So when you see a subepidermal bulla, the first question that you need to ask yourself is there any inflammation associated with the bulla? So if you see a lot of inflammation, then what is the kind of inflammation? So if I go high power here, you can see like you can see the orange kind of granules within this cell. So you know that you are dealing with a lot of eosinophils. So you have a subepidermal bulla with a ton of eosinophils within the bulla as well as in the dermis. So if I go high power in the dermis, I can see all these scattered eosinophils. So 80-year-old, so a very old female or a male person with tense blisters, and then biopsy shows this subepidermal bulla with a ton of eosinophils within the bulla and within the dermis, then the diagnosis is bullous pemphigoid. It can also occur sometimes in a bullous drug eruption. It can also occur in a bullous arthropod bite. So again, the clinical history is always very, very important. In inflammatory derm paths, making a diagnosis in a vacuum is always suicidal. You always have to like look at the clinical history, make sure that you have a very good relationship with your dermatologist so that you can talk to them whenever needed, pick up the phone, very easy to communicate with them, because when you do a clinico-pathological correlation, it is always much better. You can always make a much better diagnosis. So a very important relationship between the clinician and the pathology person is very, very important for getting the right diagnosis to the patient, because the same histology can occur in multiple things. It can occur in a bullous drug eruption, it can occur in bullous pemphigoid, it can occur in a bullous arthropod bite. There is no way a pathologist can like differentiate these three without the clinical history. So that clinical history becomes very, very important. And that is the reason it is like for the trainees also, like if you get this description and the pathologist doesn't give you a final diagnosis, if you have like really focused on dermatopathology during your training, then for you it becomes a much easier diagnosis, because now you know what the histology is showing, and based on the histology and the clinical features that you see in your patient, you can then easily come to a diagnosis. So that is the other part of the coin, where the dermatologist also has to be very good at understanding the dermatopathology report, because if they can figure out what the microscopic description is trying to tell them, then they can easily like come to a better diagnosis and treat the patient in a much better way.
Dr.
So
Rajendra,
subepidermal bulla with a ton of...
Dr. Rajendra, what about EBA? How do you all differentiate that?
Like EBA is like normally one of like the first thing is like we have as a pathologist and as a clinician, like always very important to remember is common diagnosis first. So like if I see this kind of an infiltrate, like we will talk about the common diagnosis that we first thought about. But yes, sometimes this could be some rare diagnosis like an EBA. EBA is usually like a very cell poor infiltrate. Most of the times it is a very cell poor infiltrate. So I don't see too much of inflammation within the dermis. And it can also present with sometimes neutrophils within the dermis and sometimes eosinophils in the dermis. So the clinical history, the histology, and then the immunofluorescence will help me make the diagnosis. So many times we have to take all the contact features like what is the clinical history, what does the biopsy show, what are the more common diagnoses, what are the uncommon diagnoses, and then go to the immunofluorescence studies. So if it is bullous pemphigoid, then I'm going to see the linear IgG and C3 at the dermal epidermal junction. Case 13 is a 6-year-old boy brought to the pediatrician with a 1-week history of itchy, blistering rash on the lower abdomen, and then that has spread to the groin and the buttocks. So here again we are still in the bullous chapter. So like I said, like first is where is the bulla? So the bulla, what is the level of the split? Here you can see again the level of the split is at this below the epidermis. So it's again subepidermal. So it's a subepidermal split. That is the first thing. So we know that we are dealing with a subepidermal split. Then is there inflammation? Yes. What is the inflammation here? So in the previous one we saw a lot of eosinophils. Here what do we see here? So if we go high power here, we see a lot of neutrophils here. Here you can see the bilobed nucleus. So there's a lot of neutrophils along with some even leukocytoclasia. So leukocytoclasia is the nuclear dust that you see here. So if I keep going at the dermal epidermal junction, I can see this nice bilobed nucleus. So I know that I'm dealing with a neutrophil. So there are some eosinophils here, but the predominant cell type is a neutrophil. So if I go back to what is the pattern here, this is a subepidermal bulla with lot of inflammation, predominantly composed of neutrophils. So when I see this kind of pattern, then I'm most likely dealing with linear IgA vesiculobullous disorder. So then I do the immunofluorescence and I will definitely see that linear IgA pattern at the dermal epidermal junction, which will help me confirm the diagnosis. So subepidermal split with a ton of neutrophils, you think of linear IgA vesiculobullous disorder, you do your immunofluorescence, and then that should give you the diagnosis. Still keeping with the same kind of chapter, here is a 50-year-old man that presents with fragile skin that is mostly with blistering on the back of his hands. Now here again there is a split here. So where is the split? It is at the level of the subepidermis. So again you have the intact epidermis and then below that you have the bulla. But now what is different here? I don't see a ton of inflammation here. So this is a cell poor infiltrate. That would be one of the features that I would normally see in also the EBA, where I will not see too much of inflammation. There are neutrophilic rich and eosinophilic rich variants of EBA, but most of the times it is a cell poor. What do I mean by cell poor is that I don't see too much of inflammation in the dermis compared to what I saw in the 2 previous biopsies. Here there was a lot of inflammation at the dermal epidermal junction, and here also we saw a lot of inflammation here in the dermis. When we come to this biopsy, in the current biopsy, it's predominantly a cell poor infiltrate here. So a subepidermal split with very little inflammation. What are the other features that we see here? Here you can see that this dermis does not collapse in spite of being separated out from the epidermis. There is no anchor. It is not collapsing basically. And why is it not collapsing? Because it is a kind of a sclerotic dermis. And because this is a little bit of a sclerotic dermis, you can see that dermal papillae are still maintaining their outline, and this is what is termed as festooning of the dermis. So the term that is described in the books, that is festooning, which is this dermal papillae, they still preserve their outline. The other feature that we see here is this basement membrane that is still stuck to the roof of the blister. So these are known as, when you read about this, you are going to, the term that is described in the book is caterpillar bodies. So what are caterpillar bodies? Are these fragments of basement membrane that are still stuck to the roof of the blister. So if you take all these features into context where you see the subepidermal split, which is cell poor, you see the festooning, you see the caterpillar bodies, and there is some thickening of the blood vessel wall basically. So if I do a PAS, I'm going to see this the PAS is going to highlight this thickening of the blood vessels within the dermis. Combination of all these features should help you make the diagnosis of porphyria cutaneous tarda PCT. So like if you see all the combination of these features, then you should be able to make the diagnosis of PCT. And the history was also very classic, where you had this fragile skin and blistering on the back of his hands that are commonly seen in PCT. Case number 15, 38-year-old woman present with widespread rash that began three days ago, and she was taking some kind of allopurinol. So now let's look at the biopsy here. So again, when you start from the top, not too much of changes in the stratum corneum. The epidermis looks pretty normal. The dermal epidermal junction also looks pretty normal. So predominantly the epidermis is normal, but there is some kind of changes in the dermis. What do we see in the dermis? We see this superficial and deep. So superficial, this is the superficial venous plexus. This is the deep venous plexus. So you see superficial and deep perivascular inflammation. So whenever you see this superficial and deep perivascular inflammation, you zoom into the slide and you try to see what is the kind of inflammation that I see here. So I see that it is predominantly composed of these lymphocytes, but then there are scattered these orange granules that you see here. So you can see this orange granules here. There's another orange granule here, another one here, and these orange granules tell you that you are dealing with a perivascular lymphocytic infiltrate with admixed eosinophils. So when you see this pattern, which is known as perivascular dermatitis, with not too much changes in the epidermis, sometimes you might see some disc keratosis within the epidermis. But the more important feature to focus on is the perivascular inflammation, lymphocytic with admixed eosinophils. If you see that pattern, given the history that the patient recently had taken some drug and then he developed the rash after taking the drug, this is very compatible with a drug eruption. So in a drug eruption, you normally see superficial and deep perivascular inflammation composed of lymphocytes with scattered eosinophils within the entire dermis. Again, clinical history very, very important, because the same pattern can be seen in an arthropod bite. The same pattern can be seen even in patients of bullous pemphigoid where they don't develop the bulla initially. So that is known as the urticarial phase or the prodromal phase of bullous pemphigoid. So again, clinical history, talking to your dermatologist becomes very, very critical if you want to make the diagnosis right, basically, because the same histology can be seen in multiple different conditions. So drug eruption, arthropod bite, urticarial phase of BP, all of them are going to show you a very, very similar histology. In urticarial phase of BC, sometime in BP, sometimes you are going to see eosinophilic exocytosis. What do I mean by that is some eosinophils going into the epidermis. Exocytosis, that is the term that is used. So if you see eosinophilic exocytosis, think of BP, look at the clinical history. Is this patient an older patient? Is it a rash? Does the patient have some blisters? And then if you talk to your clinician, then you can suggest that maybe you should do immunofluorescence to root out an urticarial phase of BP. Case 16, 14-year-old boy presented with 2-week history of recurrent itchy rash that began on his trunk and then spread to the arms and the legs. So again, younger patient with a rash. And the other very important feature that here was in the clinical history was this hemorrhagic crust. They had some hemorrhagic crust on the for the rash, basically. So now let's look at the biopsy here. So if we start from the top here, we see hyperkeratosis, we see parakeratosis. So you can see the neutrophil, the presence of the nuclei within the stratum corneum. So hyperkeratosis with parakeratosis. The epidermis, what do we see here? We see some mild spongiosis. You can see that there is spaces between the keratinocytes, But then also we see a lot of lymphocytes within the epidermis, which is termed as lymphocytic exocytosis. We talked about the eosinophilic exocytosis. Here you see lymphocytic exocytosis. And what does that mean? That means that the lymphocytes are also going into the epidermis. So you see a lot of lymphocytic exocytosis. If I keep looking at the epidermis, I'm going to see some scattered disc keratosis. So there is scattered disc keratosis within the epidermis, where we talked about the pinkish cytoplasm with the pycnotic nuclei. And then you see this infiltrate in the dermis. So we see this infiltrate in the dermis that has a very typical wedge shape. So I could draw like an arrow, like a line here, and I could draw like a line here. So it's almost like a wedge shaped inflammation within the dermis. So the combination of all these features with the young patient, the hemorrhagic crust, hyperkeratosis, parakeratosis, spongiosis, lymphocytic exocytosis, some dyskeratosis within the epidermis, and then this wedge-shaped infiltrate in the dermis that is mostly composed of lymphocytes. All the combination of these features help me make the diagnosis of pleva, which is pityriasis lichenoides et varioliformis acuta. So pleva is the diagnosis when you see all the combination of the features. And what are the combination again? Hyperkeratosis, parakeratosis, spongiosis within the epidermis, a lot of lymphocytic exocytosis, some scattered dyskeratosis within the epidermis, and then the wedge-shaped lymphocytic infiltrate within the dermis. Very eosinophils are very uncommon in pleva. So like most of the times, if I see eosinophils, I will doubt my diagnosis. Like I will go back and look at the clinical history and see whether I'm dealing with something else. And a very similar histology might be seen in a CD30 lymphoproliferative disorder, which clinically will also show you a very similar history. In those conditions, you will see some eosinophils and you will see some large cells within the dermis. So those are the differential diagnoses to think of both clinically as well as histologically when you're thinking of pleva. Case 17, I could spend more time on each biopsy, but we have to go through 100 cases, so we will have to just keep going as quickly as possible. Case 17 is a 48-year-old male presenting with multiple asymptomatic pepper-like reddish-brown macules on the lower leg. So you know that you're dealing with something that is related to the blood vessels. So here when we look at this biopsy that has come from the lower leg, let's always make this straight. And we will share this presentation with you. So when you go back home, you can look at these cases on your own and also try to try to remember all the features that were described for every diagnosis. So here, what do we see here? So what we see here is a normal kind of hyperkeratosis on the top. The epidermis shows a little bit of a mild spongiosis, somewhat. But the more important feature that we see here is this superficial perivascular lymphocytic infiltrate that we see here, but with a lot of red cell extravasation. So you can see all these red cells here. So the epidermis shows you a lot of red cell extravasation. And that is what is giving the history of this reddish pepper-like reddish-brown macules on the lower legs. So when you say, and they do not blanch with pressure and there is no history of trauma or coagulopathy. So this pepper-like reddish-brown macules on the lower leg are related to the lot of red cell extravasation that we see in the papillary dermis. So you see a lot of these red cells within the papillary dermis that is giving that clinical impression. And this is what is pigmented purpuric dermatosis, or Schamberg's disease is the other term that is used for this one. So superficial perivascular lymphocytic infiltrate with a lot of red cell extravasation within the papillary dermis is what you're going to see histologically when you're thinking of Schamberg's disease or pigmented purpuric dermatosis. Case 18, 28-year-old woman presented in midwinter with painful, itchy red purple lesions on the fingers and the toes. So they were most limited on the fingers and the toes. So here is the biopsy. So like even if you were not given the clinical history that this is a biopsy from the fingers and toes, this very thick hyperkeratosis should let you know that this is an acral biopsy. Most of the time that should give you the clue that you are dealing with an acral biopsy, because that is the normal histology of the acral skin, where you see a very thick hyperkeratosis in the stratum corneum. So that is a typical histology of a normal skin within the acral sites. So you know you are dealing with an acral biopsy. And then what do we see in the epidermis? There is a little bit of a mild spongiosis and then a little bit of dyskeratosis also. But if you go low power, there is a superficial and a deep perivascular lymphocytic infiltrate again. So you can see that it is mostly composed of lymphocytes. What is the other striking feature that I see here is this papillary dermal edema. So I see a little bit of a spaces within the papillary dermis, and what the spaces are because there is some kind of edema or fluid collection within the papillary dermis. So there is papillary dermal edema with associated with superficial and deep perivascular lymphocytic infiltrate, which is also very characteristically seen around the eccrine gland. So here you can see these are the eccrine glands here and in the lower part of the dermis, and this inflammation is also seen in the around the eccrine gland. So that is another very characteristic feature that we see in this condition. So if I go back, what are the features that we see here? We see that we are dealing with an acral biopsy. There is papillary dermal edema associated with a superficial and deep lymphocytic infiltrate associated with peri-eccrine inflammation. So a combination of all these features with the clinical history should help you make the diagnosis of perniosis. So that is what is we see in perniosis. Similar things might also be seen in lupus. So definitely connective tissue disease is always going to be in the differential. So again, serology presence, like connective tissue is going to show you a lot of mucin. You can do the alkane blue and the colloidal iron. Here you don't see a lot of the vacuolar interface changes that we saw in the biopsy of discoid lupus. So we don't see that very prominent vacuolar interface changes. And then again, the clinical history, this is more limited to the acral sites, should help you make the diagnosis of perniosis. Case 19, 35-year-old woman presents with a gradual expanding red rash on the trunk and upper arms. So these are annular erythematous plaques. So these are rounded erythematous plaques with central clearing and trailing scale. Here is the biopsy here. So again, starting from the top, there's some parakeratosis. So you can see some parakeratosis here. The epidermis may be a little bit of spongiosis, but not too much of spongiosis. There's some spongiosis here. And then we see this perivascular infiltrate within the dermis. Now, what is difference between this perivascular infiltrate and the one that we saw last time? So if you go back to the biopsy that we saw last time here you can see that the lymphocyte infiltrate is, yes, it is perivascular, but it is also a little bit interstitial. So interstitial means between the blood vessels within the, so it is a little bit spread out within the dermis also. You can see like it is a little bit spread out within the dermis also. So it's a little bit what we call as a little bit of an interstitial also. But if you look at this one, like this is very characteristic where it is termed as a coat sleeve pattern. What is a coat sleeve? Like it is the sleeve of a coat is normally like very tight. They try to keep it a little bit narrow, so it is a tight kind of coat sleeve. So this pattern is termed as a coat sleeve pattern of the infiltrate. So where it is very tightly hugging the vessel. So around the vessel you can see this is a very tightly like the lymphocytes almost like aggregate around the vessels in a very tight coat sleeve pattern. The term is coat sleeve. So if you see this coat sleeve pattern of lymphocytic infiltrate, and it is not like going into the dermis quite a bit basically. So it doesn't have that interstitial pattern that you saw in the previous biopsy. So this coat sleeve pattern of lymphocytic infiltrate that is perivascular is very characteristic of erythema annularis centrifugum. And we saw that this was annular lesions that were scattered throughout the skin. So the clinical history of these annular lesions with this perivascular infiltrate that has this very coat sleeve kind of pattern where you can see that they are very tightly hugging, like associated with the vessel, is very typical of EAC, which is erythema annulare centrifugum. In the case 20, 42-year-old woman presents with this asymptomatic skin lesion on the back of her hands that has slowly enlarged over several months. So these are smooth, firm annular plaques. So again, you have a little bit of an annular plaque that is located on the dorsal aspects of both ends. So again, you are dealing with something that clinically appears as annular or rounded lesions. So when it comes to annular and rounded lesions, then we have to think of a couple of differential diagnoses. So here, when we look at the biopsy here, what do we see here basically? We see this very nice kind of a palisaded granuloma. So you can see like this is almost like forming like a fence. What does palisade mean? Palisade in literal terms means either a fence that is around the house or a necklace. Those are the two terms where we use a palisade. So this is either like a fence around the house or like a palace or like a necklace. So this is a palisaded granuloma. So what does a like? And if you look at this, it is composed of these larger cells that have this ample cytoplasm, and these are what is termed as macrophages. So these are all macrophages within the dermis. So this is a collection of macrophages within the dermis. So whenever you see a collection of macrophages within the dermis, that means it is a granuloma. Collection of macrophages within the dermis is termed as granuloma. So this is a palisaded granuloma. So what we see is this palisaded granulomas. Again, there's another one here. There's another one here. And it is composed of macrophages associated with some lymphocytes. So you can see there are lymphocytes here, small, these blue cells here. And then you see the cells that have this large amount of pinkish cytoplasm. These are the macrophages here. So we see this palisaded granuloma. Now if you go and look at the center of the palisaded granuloma, you can see that there is this collagen bundles, that some of them are a little bit distorted. So these are not completely necrotic, but if you compare them to this normal collagen bundles that are outside of the palisade, and you compare them here, there is a little bit of a discoloration and they are somewhat distorted. And this is necrobiosis, what we call as necrobiosis of the collagen bundle. What does necrobiosis mean? That they are not completely necrotic, but they are also not completely normal. So if you look at a normal collagen bundle here, this is a collagen bundle here. You can see this normal collagen bundles. But if you go to within the palisade, they are a little bit distorted and they're getting towards necrosis, but not completely necrotic, and that is what is known as necrobiosis. So going back to all the terms that we described, what we see is a palisaded granuloma that is around necrobiotic collagen. And if I do a mucin stain, I might see increased mucin within the granuloma. So if you see this palisaded granuloma around necrobiotic collagen, here again similar feature here, with the history of these annular lesions on the dorsal aspects of the arm, then we know that we are dealing with granuloma annulare. So that's a very classic feature for granuloma annulare, where you see this palisaded granulomas around necrobiotic collagen. Keeping on that same theme, this is a 55-year-old woman with a 10-year history of rheumatoid arthritis, and then she's developed this skin lesions. So again, now if you look at this biopsy here, we'll see a similar kind of that palisaded granuloma that we saw in the last one. So you see this macrophages that are forming like a palisade. But now what is different in this one? Like one, it is in the deeper part of the dermis. So here you can see like these are more in the reticular dermis. The second very important feature is when you go high power within this palisade, I don't see the necrobiotic collagen here. What do I see here? It is more of a very pinkish, reddish collagen that I see here. And the histological term to describe that is fibrinoid necrosis. So this is like a fibrinoid necrosis, which what does it mean? This very reddish, pinkish collagen that I see within the palisade. So I see this palisaded granuloma. So this collection of macrophages and lymphocytes that I see forming like a palisade, which I told you like is a fence or a necklace. Again, you can see the same thing here. Same thing here. And if I go to the other part of this biopsy here, I see the same thing here. So you can see that this palisaded granulomas around this very fibrinoid degeneration of the collagen bundles, and that is very characteristic of a rheumatoid nodule. So the palisaded granulomas can be seen in granuloma annulare, they can be seen in rheumatoid nodule, and they might also be seen in another condition called necrobiotic xanthogranuloma. So those are the three main conditions: granuloma annulare, rheumatoid nodule, and necrobiotic xanthogranuloma. So in the granuloma annulare, if you go within the palisade, you see this collagen bundles that still preserve their outline, but they are a little bit necrobiotic, and you can see increased mucin within the palisade. In fibrinoid degeneration, in rheumatoid nodule, you see this fibrinoid degeneration within the granuloma. And if it was necrobiotic xanthogranuloma, I would see a lot of plasma cells. I'm going to see giant cells, and I'm going to see necrobiosis, extensive necrobiosis, and that is where it necrobiotic xanthogranuloma. But again, all three conditions are going to show me the palisaded granulomas. So case 22, 42-year-old woman with a history of type 1 diabetes, and then presenting with these lesions on the shin. So we know that the patient has diabetes, and these are lesions, erythematous lesions on the skin. So most of the times, like, you know what you are looking for basically. So what do we see here? We see this, if you look at this at low power, there is this layer of inflammation, there is this layer of sclerosis, layer of inflammation, layer of sclerosis, so it's almost like layering of the sclerosis and the inflammation. And what do I mean by sclerosis is this very pink kind of papillary dermis. So when you see the sclerotic epidermis, sclerotic dermis, that is what is termed as sclerosis, which we also saw in that lichen sclerosis. We saw that very pink hyalinization of the papillary dermis. Here you see this hyalinization of the reticular dermis. And then within the layer of inflammation, what do we see here? We see this lymphocytes, and we also see giant cells. So we can see some of the giant cells, and then we see associated plasma cells. So you see giant lymphocytes, you see giant cells, and then you see some associated plasma cells within the layer of inflammation. So you see layering of the sclerosis, and you see of the layering of the inflammation, and that is what is termed as a cake layer pattern. So this cake layer pattern of sclerosis with inflammation is very characteristic of NLD, which is necrobiosis lipoidica, which can occur in diabetes. So these are patients that could have diabetes, not always associated with diabetes, but could have diabetes. And then they develop this erythematous lesion on bilateral shins. And when you do this biopsy, you see this cake layering pattern where you see the clearing of the inflammation, sclerosis, inflammation, sclerosis. And when you go high power on the inflammation is predominantly composed of lymphocytes. You can see this giant cells where you see this multiple nuclei within the giant cells. So there's all these giant cells within the inflammation. You see the lymphocytes, and if I keep looking around, I'm going to see also plasma cells. So if you see all this pattern, then you know you're dealing with NLD, which is necrobiosis lipoidica. Case 23, 50-year-old woman presents with sudden onset of fever and painful red plaques on the upper limbs and the face. History of some arthralgias. So what does the clinical show? Several tender erythematous, edematous plaques on the forearms and the cheeks. So, and the other very important history was like this was like a fever and painful red plaques. She has a history of myelodysplastic syndrome. That is the other very telltale sign of what the biopsy might show. The patient has some history of some kind of a lymphoma. So when we look at this biopsy here, it's a very busy dermis here. So you can see like there is quite a bit of inflammation within the dermis. So whenever you see a lot of inflammation within the dermis, the important feature is to what is the inflammation composed of. So if we go high power, we can see that this inflammation is predominantly composed of a lot of neutrophils here. So there's a lot of neutrophils in the inflammation, mostly neutrophils. So this is a kind of a neutrophilic dermatosis. So whenever I see a lot of neutrophils within the dermis, the first question to ask yourself is, do I see any vasculitis? So you have to go high power and then look at the vessels. So you look at all these vessels here. they are pretty clean here. I don't see any kind of inflammation that is very predominantly around the vessels here. So again, if I go, this is the blood vessel here. I don't see any kind of vasculitis here. So I see a lot of neutrophilic dermatosis with no vasculitis. Sometimes I might see some leukocytoclasia. What does leukocytoclasia mean? Means that the leukocytes break down basically. So when they break down, it is clasia means breaking down, and leukocytoclasia means breaking down of the leukocytes, which is neutrophils. When they break down, their nuclear dust might be seen scattered throughout the lesion. So there is a lot of blue dots that you might see associated with any kind of neutrophilic dermatosis. But there is no vasculitis. So although I see the leukocytoclasia, I don't see the vasculitis. And then there is a little bit of a papillary dermal edema that I see here. So papillary dermal edema associated with a neutrophilic dermatosis in a patient that developed this painful nodules that had lymphoma, then you know that you are dealing with Sweets syndrome. So neutrophilic dermatosis is very commonly seen in Sweets syndrome. 36-year-old male presented with a 5-day history of a rash on the lower legs. Again, now these are palpable purpuric papules. So you know you are dealing with a purpuric lesion basically. So when we look at the biopsy here, again there's an inflammation in the dermis. So now when we go and look at the inflammation, what is it composed of? We see a lot of, again, neutrophils within the dermis. So when we see neutrophils, the first thing to look for is, do I see any vasculitis? So let's go around the vessel and see if I see any vasculitis. So what does vasculitis, how do you define vasculitis in the skin? Vasculitis in the skin is defined by the fibrinoid degeneration that I see around the vessel wall. So this very pink kind of hyalinization that I see around the vessel wall is what defines vasculitis in the skin. So I see this fibrinoid degeneration around the vessel wall, which was not present in the Sweets syndrome. So if I go in the Sweets here and I look at the vessel here, so these are vessels here in the papillary dermis. You can see this is the vessel here. There is no kind of pink hyaline material around the vessel wall. When I look at this biopsy here, and I look at the same vessels here, but now there is this very large amount of this pink fibrinoid degeneration around the vessel wall associated with the neutrophilic infiltrate, and then I can also see the scattered leukocytoclasia. So you can see these blue dots here. So this blue dots here is all these blue dots here is where the neutrophils have broken up, and you can see this nuclear dust, which is the leukocytoclasia scattered throughout the epidermis. So there is leukocytoclasia associated with the fibrinoid degeneration on the vessel wall, which is the term for vasculitis. So leukocytoclastic vasculitis. That is your diagnosis when you see all this. So neutrophilic infiltrate in the dermis. There might be sometimes eosinophils admixed because if it is associated with a drug, but mostly neutrophils associated with leukocytoclasia with the fibrinoid degeneration on the vessel wall, which is vasculitis. So then all this combination of features help you make the diagnosis of leukocytoclastic vasculitis. Case number 25, 48-year-old male presented with a 3-week history of fatigue, weight loss and muscle aches. Now if we look at this biopsy here, most of the action is happening in this vessel around the deep dermis. So the epidermis is pretty normal, the dermal epidermal junction is pretty normal, the dermis is pretty normal, but then there is something happening in the subcutis. And what is happening in the subcutis? I see like there is a big vessel here, so a medium sized vessel with a lot of inflammation around the vessel. So this is medium vessel vasculitis, where I can see this large vessel here associated with a lot of inflammation around the vessel wall. So there's this medium vessel vasculitis here. There's another medium vessel vasculitis here. So when I see this medium vessel vasculitis, then I have to think of polyarthritis nodosa. So polyarthritis nodosa, what are you going to see? You are going to see this medium vessel, that is the size of the vessel, vasculitis, so this neutrophils and eosinophils and fibrinoid degeneration around the vessel wall in the subcutaneous tissue. And they can be at various stages. So some of them will show you a lot of vasculitis, some of them will show you early vasculitis. So this one here shows you like early vasculitis here. We start seeing the inflammation around the vessel, and some of them are predominantly quite drastic, where you see a lot of inflammation around the vessel wall. So at various stages, medium vessel vasculitis is what is seen in polyarteritis nodosa, PAN. Moving on to 26, 52-year-old woman with a history of chronic hepatitis C presents with recurrent episodes of palpable purpura again. So there is again this purpura, but now in the last purpura what we saw was the leukocytoclasia with the vasculitis. Now if you look at here, there's not too much of I don't see that fibrinoid degeneration around the vessel wall. So definitely I'm not dealing with a vasculitis. But what do we see here? What is the difference here that we see here? We see there's a lot of like necrosis that is starting to begin in the dermis. So there you can see some of the areas are starting to become dead. So why is this happening? Because the vessels are a little bit damaged, and some of the vessels show you this starting to show you hemorrhage within the vessel wall, and then some of them also start showing this thrombosis within the vessel wall. And when I do a PA stain, I might see this thrombosis becoming quite prominent basically. So there is this thrombosis within the vessel that is related to some kind of a vasculopathy. So this is a case where the patient had cryoglobulinemia, which is a kind of a vasculopathic disorder. So they present with purpuric lesions, but when you look at the biopsy, you don't see the neutrophils, you don't see the vasculitis. What you see is this vessels that have this thrombi within the vessel. So I can see the thrombi within the vessels that can be highlighted with the PA stain. So if I do look at these vessels, there is thrombi within the vessel that can be highlighted, and then the dermis starts becoming a little bit necrotic because the vessels are not allowing the blood supply to go easily to the dermis. So many of these patients will present with some kind of a little bit of a necrotic lesion in the skin. Whether it is DIC, whether it is cryoglobulinemia, all of these conditions are going to show you this clogged vessels with thrombosis within the vessels. And sometimes you'll have to do a PA stain to look at the thrombosis within the vessels. Case 27, 26-year-old woman present with painful red bumps on the shin. So clinically, what do they multiple tender erythematous nodules on the anterior aspects of both lower legs. So younger patient, on the lower legs around the shin, they have this erythematous nodules and they are a little bit tender. So now when we look at this biopsy here, we see that the epidermis is pretty normal, not too much change in the epidermis. The dermal epidermal junction is pretty normal, but then there is some inflammation in the dermis, but the main action is happening in the subcutaneous. So this is the subcutaneous fat, where you see that the septa are quite thick. Normally the septa are very thin like this basically, but in this one the septa are quite thickened. And why are they thickened here? So if we go here, we can see that there is fibrosis of the septa with a lot of associated inflammation, and the inflammation is composed of lymphocytes. There are some admixed giant cells, and I might also see some plasma cells and eosinophils. So there is this fibrosis and thickening of the septa within the subcutis associated with acute and chronic inflammation. So I can see a lot of lymphocytes, I can see giant cells and all of that. So whenever you see this is a septal paniculitis. So when we talk about paniculitis, it can either be only septal or it can be septal and lobular. So these are the lobules of the subcutaneous fat, and these are the septa here. So normally the septa are very thin, but in this condition the septa are quite thickened and fibrotic, associated with a lot of chronic inflammation. And there is a little bit of inflammation that overflows into the lobules, but most of the lobules look pretty normal basically. So the lobules are not affected too much. So if it was a lobular panniculitis, you might see also distortion of the lobules. Here the lobules are not affected too much. There is inflammation that is overflowing from the septa, but as you go deeper into the lobules, they look pretty normal. So this is a form of a septal panniculitis, and the classic history was this erythematous nodules on the anterior aspects of both legs. So associated with the septal panniculitis, so you know you are dealing with erythema nodosum. Very, very classic case. Keeping with the same now reaction pattern of the panniculitis, this is a patient that had lupus, and they developed this lesions on the upper arm and the thigh. So now when we look at again this biopsy here, this one again there's a lot of action that is happening in the subcutis, but now it is not only the septa that are affected, but also the lobules that are affected. So here you can see that there is a lot of inflammation within the lobules, and the lobules are quite distorted here. You can see that the lobules are quite distorted here because the inflammation is also affecting the lobules. So the overall reaction pattern now is a septal and a lobular panniculitis. So what you see is a septal and a lobular panniculitis. If I go high power here, I can see that some of the lobules also show this hyalinization within the lobules. So that's another characteristic feature of this condition, where you see hyalinization, which is again the sclerotic-like lesion that we saw in the NLD, which is the necrobiosis lipoidica, or we saw the hyalinization within the papillary dermis and lichen sclerosis. Here we see hyalinization of the subcutaneous fat lobules. So hyalinization of the lobules with distortion of the lobules with lobular panniculitis, a lot of inflammation within the lobules, and this inflammation is composed of lymphocytes, and then there is also plasma cells. So here you can see the nucleus that is pushed to the periphery with the cytoplasm that shows you the horseshoe pattern here. So you can see associated lymphocytes. So going back, septal and lobular panniculitis with hyalinization of the lobules and the inflammation composed of lymphocytes associated with plasma cells. So lymphoplasma cellular infiltrate. So if you see a combination of this feature, then you're dealing with lupus panniculitis. So the more important thing is this is a kind of a septal and lobular panniculitis, and when you see that, then you have to think of either lupus panniculitis or some kind of other panniculitis that is associated with the lobules. The hyalinization of the lobules along with the lymphoplasmacytic infiltrate and the history that the patient already had a history of SLE should help you make the diagnosis of lobular panniculitis. 34-year-old woman presented with patch of thickened skin on an abdomen that gradually enlarged. So what we see is this well circumscribed, so it is not spread throughout the skin, indurated, hypopigmented plaque. So here is the biopsy here. So like very classic biopsy where you see the rectangular shape of the biopsy. Normally, whenever you look at any biopsy that doesn't have that rectangular shape, it usually has a wedge shape because it normally thins out at the lower layer. So like whenever you look at another, let's look at another biopsy that shows you, like here you can see like this is a wedge shaped biopsy. Normally, like as you go deeper, you see, but in this one, the term that we use is a rectangular kind of biopsy. So you see like a rectangular kind of biopsy. And why is this rectangular? Because the skin is very sclerotic. Again, like what does the word sclerotic mean? Whereas you see this very pink hyalinization of the collagen. So the first striking feature is this rectangular biopsy where there's a lot of hyalinization of the collagen bundles. The adnexs are mostly gone. I don't see too many follicles and all of that. So adnexs are mostly gone. There is mild inflammation. So I can see some mild inflammation around here. But very characteristic is this the sclerosis of the dermis. So sclerosis of the dermis with loss of most of the adnexa and the rectangular kind of biopsy that I see here. And the other feature that I see here, if I go and look at you can see like these are the eccrine glands here. You can see all the eccrine glands here. So let's go to another biopsy that shows the eccrine glands. I just want to show you that most in the normal skin, when we see the eccrine glands, no, it's not here. Here. So you can see the eccrine glands here. They are normally associated with some peri-eccrine fat. You can see the subcutaneous the fat lobules here. So normally when you see the eccrine glands in the deeper part of the dermis, they are associated with peri-eccrine fat. So when we come to our biopsy, you can see the eccrine glands here, but they lose the peri-eccrine fat basically. So the eccrine glands lose the peri-eccrine fat. So when we go back to the features, rectangular biopsy, very sclerotic dermis, loss of adnexa, and loss of peri-eccrine fat. And then when you go and look at the inflammation, it is a mild lymphocytic infiltrate with sometimes plasma cells. So combination of these features should help you make the diagnosis of morphia. Very similar thing will happen in scleroderma, but then that is more generalized, and when it is more like localized, then it is morphia. When it is more generalized, it is scleroderma. But those are the features that you'll see in morphia/scleroderma. Case number 30, 45-year-old woman presented with a chronic itchy rash on the upper back. So what do we see? Multiple hyperpigmented firm lichenoid papules, giving a rippled appearance. So look, so again, like where is the biopsy? This is mostly on the upper back. So lesion mostly on the upper back here, and they give you a rippled appearance on the back. So when you see this, and this is the biopsy here. So this is one of the invisible dermatosis, because sometimes the skin looks pretty normal here. So hyperkeratosis, pretty normal. Epidermis pretty normal, nothing much here. There's some perivascular inflammation here, and that's about it. And then the dermis looks pretty normal. So then what is the diagnosis here? So let's go a little bit high power and try to see if we see anything else here. So if we go high power here, we start seeing a little bit of a pigment incontinence. So we start seeing a little bit of a pigment incontinence, but then very striking, you start seeing this here. So if you go high power, you see this pink hyalinized deposition within the papillary dermis with pigment incontinence. So this is the pigment incontinence, and this is the pink hyaline deposition within the papillary dermis, which was very subtle. So if you don't go high power, you can miss this diagnosis, because this would look pretty like normal skin. But then if you start looking at it very carefully, and you go a little bit high power and you start looking at the papillary dermis, because you see this pigment incontinence, you want to go here and see like why is there pigment incontinence here. And then you see this very pink hyaline material. So this is amyloid. So this is deposition of amyloid. And where is this amyloid coming from? This amyloid is coming from the keratinocytes. So when the keratinocytes get destroyed, some of the pigment gets released. And so you see the pigment incontinence in the dermis. So whenever low power shows you pigment incontinence in the dermis, one of the things that you need to always keep in mind is lichen or macular amyloidosis. So if you think about that, once you start thinking, then you go high power, then you will easily like see the pink hyaline deposits within the papillary dermis. But if you don't think about it, you can easily miss it, because it would look like normal skin. So you see this, and then you can do your PAS stain and a Congo red stain, and this would then stain with the PAS and the Congo red. But this pink hyaline deposition should let you make the diagnosis of macular or lichenoid amyloidosis. Case number 31.
Dr. Rajendra.
58-year-old man.
Dr. Rajendra Singh.
Yes.
I think you also need a break, You're going on continuously for too long a time. And the audience here also are claiming that they need a break.
Yeah, so we can.
Can we have a 15 minutes break, please?
Yep, that will be good.
I know it's an odd part of the early morning hours for you, and we're extremely thankful to you, my dear Rajendra Singh, for coming up.
No, it's okay. Like right now, it's 6:20 in AM.
6:20, 6:20. I know what it is in New Jersey at 6:20. So just 15 minutes, huh?
Yep. That'll be good.
Thank you very much, Raj. Thank you.
Yep.
Ladies, maximum ladies, and the few gentlemen around, 15 minutes break only. When I say 15 minutes, we mean 14 minutes and 60 seconds. Okay, break. Hello, ladies and gentlemen, be back here, please. I hope you all had your coffee break. Even if you've not had your coffee break, please come back. Please come back. Professor Rajendra Singh, we are ready. Can you hear me?
Yeah, I can hear you.
Thank you very much for waiting. Did you have a cup of coffee or something?
No, I had my tea in the morning. Yep.
Okay, okay. Only one cup of tea for a day. Good. Very,
no, later on I'll get the other one.
Okay.
I'll get another one.
Very controlled. Great. Yes, my dear friend, we can start.
Okay. So welcome back. So we finished the first 30 cases. So case number 31, a 58-year-old man presents to the emergency room. So what they had some red swollen warm skin on at the metatarsophalangeal joint. Here's the biopsy from that patient. So again, we see some kind of deposition within the dermis now. So like previously in amyloid, we saw the deposition in the papillary dermis. Here we see again the deposition more in the dermis here. This one is more like fibrillar. You can see like it's a little bit more fibrillar. But the more important feature that we see here is that it is surrounded by a lot of inflammation here. So there's a kind of inflammation that is surrounding the fibrillar deposition within the dermis, and this is composed of like some macrophages, some giant cells, some lymphocytes. So you can see like some large macrophages, you can see the lymphocytes, you can see the giant cells. So it is kind of a granulomatous inflammation that is associated with this fibrillar material that is deposited within the dermis, and this is very, very characteristic of gout. So you can look at the history also, like it will give you that this is most likely gout because the patient has the severe pain and swelling. This is associated with the joint, and then it is extremely tender to touch. And then based on the histology, then you can easily make the diagnosis of gout here, where you can see this fibrillar material associated with the granulomatous inflammation around the fibrillar material. Case number 32, 64-year-old woman, end-stage renal disease. Now, this could come as an emergency case because this patient starts developing these escards, black escards with surrounding induration. So you definitely want to make sure that there is no calciphylaxis. So normally this will come in as rule out calciphylaxis because the patient is developing these areas of necrosis that are rapidly spreading, mostly around the buttock area and the thigh area. So when you want to rule out calciphylaxis, what do you want to look for basically? So you want to look for calcification that is associated with the smaller capillaries in the dermis and the subcutaneous fat. So most of these biopsies, they will definitely, because they are coming from escards and necrotic skin, there will be some associated necrosis. But then you want to look for the calcification around the smaller vessels. So you start scanning the biopsy very, very carefully. And you will see definitely the bigger vessel showing the calcification, which could be even atherosclerosis. But that doesn't equate to calciphylaxis because you don't want to this is not the definition for calciphylaxis. This is more like an atherosclerotic plaque. So what you want to focus is on the smaller vessels here. So you want to focus on the smaller vessels here, where you again see the calcification deposition around the smaller vessels. So you definitely see it around the bigger ones, but then you also start seeing it around the smaller ones. And if you start seeing this in association with some necrosis, fat necrosis, then you know that you are dealing with calciphylaxis. Sometimes you have to stain it, like there are couple of stains that you can do, one CASA stain, which is a calcium specific stain, or the alizarin red stain. So there are the two stains, one CASA and alizarin red, that can highlight some of these calcification that you see in the deep in the vessels associated with the subcutis and the deep dermis. So you just have to go high power and look, otherwise you can easily not find them if you don't go high power, and then try to figure out where the vessels are, and then associated with the vessels you want to see the calcifications. 33-year-old male, 22 years, so 33, so the case number 33 is a 22-year-old woman, painful genital ulcers and fever. So these are painful and they are grouped. So multiple grouped vesicles and erosion. So you know most likely what you're dealing with when you're dealing with multiple grouped painful vesicles in the groin area. So the biopsy is taken. So what do we see in the biopsy? Here is the biopsy here. So you can see there is focal ulceration here associated with some kind of acute inflammation. So there's a lot of neutrophils are associated with acute inflammation. But then when you start looking at the necrosis or the so you can see like there is this larger keratinocytes that show multinucleation. So you see the multinucleation within the keratinocytes. And when you start looking at the nucleus, there is a little bit of a clearing of the nucleus, because if you look at this nucleus here, it is quite blue. But if you look at the larger keratinocytes, you can see that the nucleus is a little bit of clearing of the chromatin. So the chromatin gets separated out, and it goes at the level of the nuclear membrane. So this chromatin at the level of the nuclear membrane is known as margination. So the three features that are described here is like multinucleation, margination, and the other feature that is sometimes described as molding, where some of the nucleus, like when it is a multinucleated, they are on top of each other. So here you can see the two nucleus, they are like molded on top of each other. So that is the molding. There is the multinucleation, and then the margination of the chromatin, where you can see that the chromatin gets closer to the, so it's not like very blue like this nucleus. The central part of the nucleus is a little bit more lighter, and then the periphery is a little bit darker, which is the margination of the chromatin. So multinucleation, molding, and margination are the three features that you will see with this necrosis associated with a neutrophilic infiltrate in herpes. So this is a classic case of herpes where you see this keratinocytes undergoing this multinucleation, margination, and molding of the nuclei. So whenever I see a lot of neutrophilic infiltrate, that is one feature that I always want to look for, is like, so is there any kind of herpes there? So I just have to like look very carefully, and then I can start seeing these features here that we talked about. You can see like here also the chromatin is a little bit lighter, the nucleus, and then it is a little bit darker at the periphery, and the nucleus are like on top of each other, like molding on top of each other. 60-year-old male with a history of poorly controlled HIV. So there are multiple umbilicated papules and nodules. So you can see like the patient has some kind of an associated infection. So when we look at this biopsy here, so here it's very easy to see that there's a lot of granulomatous kind of inflammation here associated with some kind of a round organism here. So whenever you start seeing the spore-like organism, you start thinking of fungal infection. Now, when you start thinking of fungal infection, you have a list of differential diagnoses that you need to think about, whether it is cryptococcus, whether it is blastomycosis, whether it is coccidiomycosis, or whether it is lobomycosis or sporotrichiasis. Those are the main deep fungal infection that you normally see. So how do you differentiate between all of these basically? So yes, first you can always do the PAS and the GMS stain. That will help you decide whether this is a fungus. Sometimes, most of the times that is not needed, but sometimes if you're not sure, you can do the PAS and the GMS stains. So the PAS and the GMS stains are going to be positive. So that is the first thing. The second thing is like you look at the size of these spores actually. So yeast like the yeast or the spores, you look at the size. So how do you compare the size of these? So you compare them to the size of a lymphocyte. So a lymphocyte or a red blood cell is typically around 7 microns in size basically. So if you look at these ones here and you compare them to associated lymphocytes, they are typically very similar size to the lymphocytes. So this is around 7 microns. So if you see this is around 7 microns, you can see all these associated spores and yeast that are around 7 microns, 7 to 10 microns in size, and they are associated with this kind of a gelatinous background. So there is some kind of a clearing in the background. So this is actually cryptococcus. So cryptococcus is around 7 microns in size, that is the size of the lymphocyte or the red blood cells. So some red blood cells and then some of the organisms here. So you can see like it is very similar to the size of the red blood cell, and that will help you diagnose this as cryptococcus. A very similar organism could be lobomycosis. So lobomycosis is also 7 microns in size, but it is not a very common diagnosis. Crypto is the much more common diagnosis. But the one feature that you normally see in lobomycosis is what is called as pop bead. So a pop bead is like the organisms, they are like in almost like a tube, like one after the other connected like a tube, and that is what is known as a pop bead appearance. So in lobomycosis, they have this tubular, like where they are connected to one another, that pop bead kind of appearance. And in cryptococcus, you don't see that. And then when you, the other stain that is very specific sometimes for cryptococcus is mucicarmine. So if you do a mucicarmine or an indigo ink black stain, these will actually stain with the mucicarmine. So 7 microns in size, very similar to the size of the lymphocyte and the red blood cell. So this is another fungal organism in case number 35, where the patient has this 3-week history of verrucous skin lesion on the face and the upper arms. So again, you see a very suppurative and granulomatous inflammation here. Let's go ahead, look at the biopsy here. Here you can see there's a lot of associated inflammation here. So a lot of lymphocytes, macrophages, giant cells. So you know that you're dealing with some kind of an infectious etiology. And then when you start looking around, you can see that there are some organisms here. So you can see there's large organisms here. So when you compare it to the size of the cryptococcus, this is 2 or 3 times the size of the cryptococcus. So that was around 7 microns. These tend to be around 10 to 20 microns. So around 8 to 15 microns is the size of this one basically. And they have this budding. Sometimes they have this budding where you have this broad, like some time of them will show 2 of them together basically. So this budding is also another very common feature of fungal infection. So you can see there's a lot of these fungal infections here. Again, if you're not sure, you can definitely do the PAS and the GMS stain, and that will highlight these spores or yeast. And like the size is around 8 to 15 to 20 microns, and then that is very characteristic of blastomycosis. So the cryptococcus is around 7 microns. The blastomycosis is around 10 to 15 microns. So it is around twice the size of the cryptococcus. And then the third one that we see here, which is in this again the third case number 36, is where we see the same inflammation here, granulomatous and suppurative inflammation here. So this is the granuloma, the macrophages that we talked about, and the giant cells and the lymphocytes. So there's a granulomatous, but now you can again see the spore here, like the yeast here, which is quite big compared to what you saw in the blastomycosis or the cryptococcus. So these are like around 10 to 80 microns in size, so almost like 10 times the size of the cryptococcus. So if you look at a lymphocyte here, that's the lymphocyte, so that was the size of the cryptococcus. This is almost like 10 times the size of the lymphocyte here. So the coccidiomycosis is around 80 microns, which is 10 times the size of the cryptococcus, and the blastomycosis is around 15 to 20 microns, which is twice the size of the cryptococcus. And the base is the lymphocyte or the red blood cell that you see within the biopsy. That is your base where you can get your relative sizes from. So you compare it to the lymphocyte, and then based on that you can see that this is composed. This is very, very large, and this tend to also show this large spherule with a lot of internal microspherules. So you can see there's a lot of smaller organisms like microspherules within the coccidiomycosis. So big spore with a lot of microspherules is what is characteristic of coccidiomycosis. Again, the background is always suppurative and granulomatous inflammation. So what do you mean by suppurative and granulomatous? Suppurative means associated with neutrophils, and the granulomatous is giant cells, macrophages and lymphocytes. Moving on, like we are still in the infectious etiology. So 40-year-old man in the rural area present with several week history of a slowly enlarging painless mass. So this is some mass on the foot. Here again you can see that there is a lot of inflammation here. So let's go back and look at the biopsy here. So again associated with a lot of suppurative and granulomatous inflammation, where you see a lot of macrophages, you see giant cells, but then very classic you see again these organisms here. How is this different from the cryptococcus? This one is pigmented. So this is a very pigmented round cellular yeast structure. So you can see like there's a lot of pigment associated with this one. The Cryptococcus did not have the pigment. These ones are the pigmented. So these are known as copper pennies. So like they are very round and copper penny like, and the other term is medlar bodies. They are also termed as medlar bodies. So if you see this round pigmented yeast that is around the size of the lymphocyte, looking very similar to the Cryptococcus but pigmented, then you are dealing with a chromoblastomycosis. So again, like it depends on which fungal organism. So this one comes under the family of chromoblastomycosis, where you see this pigmented round yeast-like structures within the rhombus, and usually you don't see any hyphae. Fungal infections can show spores or hyphae. Spores are these rounded structures, and the hyphae are the one that we will see in the next one. So this is when you see only the spores, which are the medlar bodies or the copper penny-like bodies, then you are dealing with chromoblastomycosis. This is the next one, where again this is a subcutaneous nodule, and then this one also has the suppurative and granulomatous inflammation here. So let's go and look at this one here. Again, you see the suppurative, so you can see the giant cells, you can see the macrophages, you can see the lymphocytes, you can see the neutrophils. So you know you are dealing with some kind of infection again. And again here you can see the pigmented the organism here. So if I go here, this one not only has the spores but also has the hyphae basically. So here you can see like these tubular structures that you see here, these are the hyphae here. So when you start seeing the tubular structures that are the hyphae here along with the rounded structures which are the spores, so in the chromoblastomycosis you only see the spores, you only see the rounded structures, but they are pigmented. And again this one is also pigmented but also shows the spores and the hyphae. Then you are dealing with pheohyphomycosis. So that one is the pheohyphomycosis, and then only the one that has the spores, then that is the chromoblastomycosis. And then if they are non-pigmented, you are dealing with either Cryptococcus or blastomycosis or the coccidiomycosis or lobomycosis. So depending on pigmented, non-pigmented, if it is pigmented, only spores or only spores and hyphae. So based on that you can then go and classify the lesion as what is the most likely fungal organism associated with the suppurative and granulomatous inflammation. Case number 39, 33-year-old man presents with a painful ulcer. The patient had gone to a recent trip to South America, and here is the infection again. So again a ton of inflammation here. So you can see there's a ton of inflammation here. It's again like quite a bit of macrophages, there's a lot of lymphocytes, there's some neutrophils, there are plasma cells, you might even see eosinophils. But we do not see any of the associated spores or hyphae here basically. So what is the organism here? So you like if you start looking at it carefully, you'll start seeing that many of these macrophages, they have intracellular organisms. So these you can see like the intracellular organisms here. So these small rounded structures that you see here, these are the organisms that are now intracellular. So they are within the macrophages. So whenever you see these intracellular organisms, the two common diagnoses to think of, there are others, but the two common ones to think of are histoplasmosis and the other is leishmaniasis. Histoplasmosis is a fungal infection, so that will stain with the PAS and the GMS stain. So if you are not very sure whether this is histoplasmosis or leishmaniasis based on the clinical history, then you can do a stain, and the stain will help you decide whether if it's a fungal infection or a non-fungal infection. If it is a fungal infection which is histoplasmosis, it is going to stain with the PAS and the GMS stain, and then if it is not, then it is the leishmaniasis. So leishmaniasis stains with the Gimza stain. It doesn't stain with the fungal stain. So Gimza will stain positive in the leishmaniasis. People talk about in the like the marquee sign, where you see these organisms mostly around the periphery of the macrophages, but that is more like semantics describing things, because many times in histoplasmosis also you see the same thing basically. So both are intracellular organisms associated with the suppurative and granulomatous inflammation, and then one is a fungal organism and the other is a non-fungal organism. One stains with the PAS and GMS, the other stains with Gimza stain. But both of them show very similar intracellular macrophages. Within the macrophages you see a lot of these organisms here, and when you go low power you're going to see the suppurative and granulomatous inflammation. Case number 40, 29-year-old from rural India. So clinical history is very telling. Slowly enlarging numb patch. So numb patch on the forearm. So you know that most likely a patient in rural India coming has showing a numb patch. There is notable sensory loss. So most likely I'm dealing with some kind of leprosy. So now we have to just decide what kind of leprosy is this one basically. So leprosy normally will present in multiple different forms. So the most two common ones are the tuberculoid and the lepromatous leprosy. But then there are the intermediate forms and the other forms, histoid forms and the other ones. The tuberculoid leprosy tends to present with this very linear kind of granulomas that are following the nerves. So if you see this linear kind of granulomas that are composed, so these are the macrophages here, these are lymphocytes here. So you can see like this is the granulomatous inflammation here, and they are associated with a lot of lymphocytes. So if you see a linear kind of granuloma, then most likely you are dealing with tuberculoid leprosy. If you do the fight stain, you might sometimes see the organism. Most of the times it is very difficult to see the organism. So this linear granulomas, given the clinical history, should help you make the diagnosis of most likely this is tuberculoid leprosy. And then if it is the lepromatous leprosy, we will see this very dense kind of macrophagic infiltrate throughout the dermis. So this one shows you a lot of lymphocytes associated with a lot of macrophages. The very classic feature that has also been described is the presence of the Gren zone here. So what does the Gren zone mean is that you have a part superficial papillary dermis that does not show the inflammation, so it is spared. So the inflammation will start at a little bit low below the epidermis. So there is a small area of the dermis that is not involved, and that is what is known as the Gren zone. Gren zone can also be seen in lymphomas, in a B-cell lymphoma. So that places like they are described with lepromatous leprosy, and they have been described with B-cell lymphomas. So in lepromatous leprosy, you see this Gren zone. You see a large amount of macrophages within the dermis, and when you start going high power and you start looking at these macrophages, you can see that they are filled up with this bacilli. So if I do a fight stain, this is going to light up. There's a lot of these bacilli. So these are also known as virchow cells. So you can see a lot of these bacilli within these macrophages. So all these bluish structures that you see, they are filled with lepra bacilli. So I can just do a fight stain and this would actually light up quite a bit basically. So lymphocytes and dense macrophages infiltrate within the entire dermis with the Gren zone, and then it's also involving the subcutis. And when I go high power and look at these macrophages, they are filled with this bacilli which can easily be highlighted by the fight stain basically. Case number 42, 38-year-old woman with several non-itchy skin lesions. And then on examination, there are red-brown papules and plaques on the cheek and the upper back. And then also the chest X-ray shows lymphadenopathy. So now what we see here basically. So this is a biopsy that we see here. So again, there is inflammation here. But what is the kind of inflammation? So if you look at this is a lot of collection of macrophages. So these large pink cells are macro. You can see these are macrophages here. So all of these are, some giant cells are there and some macrophages. But you don't see a lot of associated lymph. There are some lymphocytes here in the so you can see like the lymphocytes are here, perivascular lymphocytes. But when you actually come to the granulomas, they are like not associated with a lot of lymphocytic infiltrate. And because of that, they are termed as naked granulomas. I don't know whoever put that name, but that is how they are described in their books. They are naked granulomas. And what does naked granuloma mean? That they do not have the associated lymphocytic infiltrate with them basically. So you see a collection of macrophages throughout the dermis, superficial and deep dermis. So whenever it is inflammatory, you know that you are dealing with some kind of inflammatory lesion. So if you see this granulomas, the first thing that we always have to do is do the PA stain to rule out a fungal infection. We have to do the fight stain and the AFB to rule out any kind of mycobacterial associated inflammation. So once we rule out all the things that can cause a granulomatous inflammation, once everything has been ruled out by doing the PA stain, the GMS stain, the AFB stain, the fight stain, so we do all of these stains, we make sure that this is not associated with any of the known infections. So once everything has been ruled out, then we can call this sarcoidosis. But remember, sarcoidosis is a diagnosis of exclusion. That is not like something that is diagnostic based on the histology. You first rule out all the other associated inflammatory stuff with the granulomas, and once that has been ruled out, then you can say that this is most likely compatible with sarcoidosis. And this history was very telling, where you saw the chest X-ray showing bilateral hilar lymphadenopathy, which is quite a bit seen in sarcoidosis. Case number 43. So this is a painful lesion that the patient developed when they were on the beach. So they were on the beach in Brazil, and they developed this while walking on the beach. So this is a central black dot. So because it is black, many people get worried, that clinician will get worried that am I dealing with something melanocytic. So and it is on the acral side, so they get more worried. So they just, it most likely comes in as rule out melanocytic lesion. So what do we see here? So we see this acral site here. Again, you see the thick hyperkeratosis here. So you know that this is acral site. But then there is this organism here. So here you can see like this organism here, which has a lot of eggs. So the what happens is, this organism, which is stungiasis, it will infiltrate the skin, and then it finds the warm, moist areas under the stratum corneum to lay its eggs. So these are all the eggs of the organism. So you can see a lot of these eggs, and then you see this, what is termed as tracheal body. So this is the actual organism, these tracheal bodies that you see here. So these are the organism, and these are the eggs of the organism. So when you see this combination of the organism with this skeletal muscle-like feature here, you can see the skeletal muscle-like feature here. So skeletal muscle-like feature, the tracheal bodies, and these large eggs of the large eggs of the organism, then this is stungiasis. And this is normally will always come in as a pigmented lesion, so it comes in as rule out a melanocytic lesion. But when you look at the history, the patient has walked barefoot on the beach, and this organism has then penetrated the skin when they were walking on the beach. Case 44, 27-year-old presents with intense nocturnal pruritus. So what you see is a lot of multiple excoriated papules, vesicles, and linear burrows. So that is another giveaway sign that most likely you know what you're dealing with when we talk about linear burrows in the web spaces of the fingers. And very, very pruritic. So the patient is like scratching all the time. So when we look at the biopsy here, this one is very obvious. Sometimes it is not that obvious, where you see this organism in the stratum corneum. So here you can see that this is a scabies mite within the stratum corneum. So very, very pruritic. It is normally associated with a superficial and deep inflammation with a lot of eosinophils. So whenever I see this inflammation that has a lot of eosinophils, and the patient is very pruritic, especially in older patients, then we definitely like try to look for these organisms. And remember, sometimes these are very difficult to find. So you might have to go through multiple levels. So like sometimes 10 slides, 20 slides, 30 slides, so that you cut through the entire block and make sure that you don't see this. So if you have to go through, one section might not show it. So if you are suspecting clinically as well as histologically that the patient might have scabies, then you have to cut through the block and look at 10, 15, 20 slides to make sure that the patient, you don't see the scabies mite within the stratum corneum. Case 45, 65-year-old man present with a slowly growing asymptomatic, well circumscribed red to brown papule on the anterior skin. And dermoscopy shows a string of pearl signs. So I'm already giving you the diagnosis, string of pearl vascular pattern. So now what is the histology here? So here you can see like this is an acanthotic epidermis, shows some sort of a psoriasiform hyperplasia. But now very, very, very easy to see that there is a very sharp demarcation. This is the normal epidermis, and there is a very sharp demarcation where the keratinocytes show a lot of clearing of the cytoplasm. So you can see like the cytoplasm is a little bit cleared compared to this cytoplasm that you normally see here. So psoriasiform hyperplasia with a very well demarcated, like very sharp outline on both ends of clear cytoplasm. And sometimes you might see an associated neutrophilic infiltrate also on the papillary dermis. Let's see if we see that here. But that is another common feature that is seen in many of these biopsies. This one doesn't have it, but you may, if you have another case, you might see that neutrophilic infiltrate in the stratum corneum. So this very sharp demarcation at both ends tells you that this is a clear cell acanthoma. That is the diagnosis here, clear cell acanthoma, where you see this acanthotic epidermis with a very sharp demarcation of the lesion from the surrounding epidermis. Case 46, 67-year-old male present with multiple skin growth on the back. So what is the giveaway here? They are waxy and they are stuck on appearance with a brown papule. So when we look at the biopsy here, we can see that the epidermis is a little bit acanthotic. So acanthotic epidermis. And then you see this pseudocyst here. So why do we call this pseudocyst? Because this is not a real cyst, although it looks like a very cystic structure. But this doesn't have a lining of its own. So when it doesn't have a lining of its own, this is known as a pseudocyst. So this is a pseudocyst here that is filled with hyperkeratosis. So if I keep cutting, this might then, so let's go to another area of the biopsy here. So here you can see, like, if I keep the cutting, this will then turn into like a large area here that is intraepidermal, and it would look like a cyst. But that is just like because this epidermis is showing a big stratum corneum here, and when you keep cutting this, it will then become like this basically. So, and these are known as pseudocysts. So you have an acanthotic epidermis with this pseudohorn cyst in the epidermis, and there is no real atypia here. So if I look here, I don't see any kind of atypia within the keratinocytes. So acanthotic epidermis with this pseudohorn cyst is very typical of seborrheic keratosis. So these are seborrheic keratosis, and the other very important feature that you will be seeing in books is what is known as the string sign. So what do I mean by a string sign is that I can take a string and I could stretch it at this layer, at this junction here, and it will like be a straight line here basically. So if I take a string and like create it and look at the base of the lesion, many of the times they will show this very straight line here basically. Not always, but sometimes, and that is what is being described as string sign in the books. But the giveaway is the acanthotic epidermis and the pseudohorn cyst with no significant atypia. And if you see that, then you know you are dealing with seborrheic keratosis. 52-year-old woman present with a solitary asymptomatic dome-shaped papule with a central keratin-filled crater. So you know, like, there is a crater here. So there is this crater here. It is filled with keratin. So histology also shows the same thing. But then you also see this endophytic kind of growth pattern here. So there is this endophytic growth pattern. So this almost looks like the pemphigus that we saw there. But this is a single lesion, so it cannot be pemphigus. So you have this acantholysis here. You see the acantholysis, and you see this endophytic growth pattern here of this. So this is an endophytic growth pattern with this finger-like projections. So finger-like projections, endophytic means going inside. Exophytic is when it is going outside. So this would be described as an exophytic, and this is described as an endophytic. So you have an endophytic lesion with finger-like projections that show this acantholysis. So if you see this, and it's a single lesion, usually present in the head and neck area, this is a warty dyskeratoma. Because clinically it looks warty, and then dyskeratoma is the dyskeratosis that we see associated with the lesion basically. So acantholysis and dyskeratosis helps you make the diagnosis of warty dyskeratoma. A 15-year-old boy present with a rough lesion on the sole of his foot. So this is a lesion on the sole of the foot. So let's look at high power. What do we see here? So another very classic case where you see this papillated epidermal hyperplasia. So papillations, so that is known as papillated epidermal hyperplasia. And then when we go high power, what do we see here? We see like there are columns of parakeratosis. So let's go and see the columns of parakeratosis here. So if I go here, I can see like there is this column of parakeratosis. You can see the column of parakeratosis. So like it is not here, it is like a column here. So papillated epidermal hyperplasia with columns of parakeratosis And these columns usually end with some kind of a hemorrhage here. So that is what you see clinically many times. You see this hemorrhagic crust on the top basically. So you see this hemorrhage on the top of the column of parakeratosis. And then within the epidermis, we see this granular layer that shows what is known as coilocytes. And these coilocytes are this cells that show this very racinoid kind of nucleus. So you can see this nucleus has this racinoid wrinkled kind of pattern here. So this reason, these are the coilocytes. So papillated epidermal hyperplasia, columns of parakeratosis ending with a hemorrhagic crust on the top. Again, this columns of parakeratosis. You can see that here with associated coilocytosis. And then the other feature that you see here is if you look at this, these are the rete ridges here. So what these have been described in the books as infolding of the rete ridges. So they are like almost like all coming together like this infolding. So they are not straight, but they are all like folding towards the center of the lesion. So you can see this is known as infolding of the rete ridges. So all these features are normally seen in verruca. So this is a viral infection verruca where you see all these features come together of the papillated epidermal hyperplasia, coilocytes, column of parakeratosis, and this infolding of the rete ridges towards the center of the lesion. A similar lesion, but this is now on the groin and it is quite big, soft, flesh colored cauliflower like papules on the penis. So again, papillated epidermal hyperplasia associated with the coilocytosis. So you can see the coilocytosis here. The racinoid nucleus that you see here, you can see the racinoid nucleus. So you know you are again dealing with a kind of a verruca lesion. But because this was on the penis, this is now most likely dealing with a condyloma. So in the penis, what are you going to see? This viral lesions that are verrucous and then show the coilocytosis that you see here. You can see the coilocytosis here. And if I do the HPV stain, most of the times these are going to be positive for the low grade HPV, which is the 6 and the 11. So the 6 and the 11 HPV are going to be positive in this one. And sometimes they become a little bit more atypical when they are associated with the high grade HPV, which is the 16, 18, 31 and 33. So if I start seeing a lot of atypia, which is then termed as bovinoid papillosis. So condyloma that becomes atypical is termed as bovinoid papillosis, and it is usually associated with a different kind of HPV, which is 16, 18, 31 and 33. And then the regular condyloma, which does not show any kind of atypia, is associated with HPV 6 and 11. So case number 50 is young patient, multiple small bumps on the trunk and the forearm. This is a beautiful lesion where you see this endophytic growth pattern, which shows this bulbous rete ridges, but then they are filled with this very pink structures that you see here. So these are all the molluscum bodies basically. So you see this Patterson, and they are also termed as Patterson-Henderson bodies. But if you see this large pink intracytoplasmic and intranuclear like inclusions, these are very, very characteristic of molluscum contagiosum. So you see this endophytic growth pattern with this intracytoplasmic inclusions of the virus, which is the molluscum contagiosum. Case number 51, again like the history is very telling. 60-year-old male, lesion on the lower leg, and they present with this lesion that are annular. So first they're annular, and secondly they show a central area of atrophy and then some raised keratotic border. When you look at the biopsy here, so that raised keratotic border, what was it actually trying to tell you? Basically, like you can see like there is this column of parakeratosis. You can see this column of parakeratosis, and beneath the column of parakeratosis, where if you look at the epidermis, you tend to see some dyskeratosis there. So you'll start seeing those pink structures that we talked about there. So and these column of parakeratosis usually will show. So it's an annular lesion, and the annule is actually caused by the parakeratosis. So you will see one ear and the other ear, because this is like an annular lesion. So like when you cut this, like it is like this. So The annule is formed by the column of parakeratosis. So you'll see one here, and then when you go at the other end, you're going to see the other one here basically. So this column of parakeratosis, and then below that column of parakeratosis, you start seeing dyskeratosis within the epidermis, and that is the classic feature that you see in porokeratosis. Porokeratosis can again present with multiple clinical presentation, but histologically, all of them show very similar feature where you have this column of parakeratosis. One classic way that I've seen some dermatopathologists describe this is like this is a train that is moving in this direction, and this is the column of smoke that you see as the train is moving this way. So the train is moving this way, and there's a column of smoke that is going that way. So this is the train, and this is the column of smoke that you see here basically. So this column of parakeratosis is what helps you define that this is porokeratosis. And if you look at the base of the column, you're going to see this dyskeratotic keratinocytes here in the epidermis. So that is very, very classic for porokeratosis, annular lesions that present like this. Case number 52, 72-year-old male present with rough scaly patches on his scalp and forehead. Here is the biopsy here. So we see a lot of parakeratosis in the epidermis. So like when we look at here, there's a lot of hyperkeratosis and some of the nuclei are retained here. Remember, like why do we see normally parakeratosis? What does actually parakeratosis mean? Parakeratosis means that in the normal skin, what happens is when the skin is proliferating, it starts proliferating from the basal layer, and then the keratinocytes keep moving towards the surface, and by the end of the cycle they get shed off, and that is the normal cycle of the skin, how it keeps on building itself. But if this whole process is hastened, there's a lot of proliferation that goes much faster than that occurs in normal skin. By the time the keratinocyte reaches to the surface, it doesn't have the time to lose its nuclei. In normal skin, by the time it gets to the surface and is shed off, it loses its nuclei. But when the skin is proliferating at a much faster rate, as happens in psoriasis or in any condition that is causing increased proliferation of the epidermis, then that parakeratosis is there because by the time it reaches to the surface, it doesn't lose its nuclei. So it doesn't lose its nuclei, so you still see the nuclei within the stratum corneum. So what does it mean that the skin is proliferating at a much faster rate than normal? So when the skin is proliferating at a much faster rate, either it is something like psoriasis, or there is some kind of underlying malignancy that is happening. Increased proliferation means some kind of malignancy. So here you can see like there is the increased proliferation that we see here with this parakeratosis on the top. So now if we are going to talk about some kind of malignancy, we want to see atypia. So when we go and look at the actual epidermis, we see that there is atypia, but this atypia is limited to the basal layer of the epidermis. The superficial part of the epidermis looks pretty normal. And what do we mean by atypia? When you look at the keratinocytes, let's go to the normal skin here. So this is the normal skin here. And you look at the keratinocytes here, they are respecting each other's boundaries. So you can see that the nucleus are all separated out. They look all very similar size nuclei. At the same layer, they are very similar size nuclei. So there is no anaplasia. And usually they do not show very prominent nuclei. The nuclei is not very prominent. Sometimes it is a little bit, but not all of them show prominent nuclei. So very similar looking nuclei that respect each other's boundaries, usually no nuclei, and they don't show a very, very dark colored nucleus. So a very dark colored nucleus means that the nucleus is proliferating much faster, so there is more chromatin, and the more chromatin, the more darker it is going to look. So usually there is no hyperchromatism. So when it is more chromatin, it is called as hyperchromatism. So one, there is no anaplasia. What does anaplasia mean? That there is no variation in the size and the shape of the nucleus or the cell. That is, if you start seeing a lot of variation that is anaplasia, or the other word sometimes is used as pleomorphism. So pleomorphism or anaplasia, what does it mean is there is a lot of difference in the size and the shape of the cells. Hyperchromatism means that nucleus looks very, very dark. The nuclear cytoplasmic ratio, which is the ratio, tends to be pretty normal. So like if you look at the nuclear cytoplasmic ratio, is the ratio of the nucleus to the cytoplasm, it tends to be pretty standard throughout the normal epidermis. But when we start going to the areas that are becoming a little bit more proliferative, then you start seeing variation. So you can see that some of the nucleus are a little bit darker. That is more hyperchromatic nuclei. Some of them start showing a prominent nucleoli. So you can see this blue dot here, that is the nucleoli. And they stop respecting the boundary. So they are they're jumbling on top of each other. But this is limited to the lower layer of the epidermis. So when it is limited to the lower layer of the epidermis, that is where we call it actinic keratosis. So actinic keratosis is the beginning of the atypia within the epidermis, but it is limited to the lower layer of the epidermis. So like lower basal layers of the epidermis, and the top layer looks pretty normal. So the top layer, you can see like there is no hyperchromasia, there is no like anaplasia, pleomorphism here. It is limited to the lower layer of the epidermis, and that is actinic keratosis. Contrast to that, this is another case here. I'll come back to this one. Let's go to this one here. So this one again, you can see like, so like if I go back to the history of this one, 70-year-old male patient with a non-healing lesion on the lower lip, and the patient has significant sun exposure. So now if you look at this lesion here, you can see like the atypia, there is a lot of atypia here. So there is a lot of atypia here. What do we again mean by atypia? So you can see there is anaplasia and pleomorphism, where there is a lot of variation in the size of the nucleus and the size of the cells. There's a lot of hyperchromasia here. You can see like some of the nucleus, they start showing a lot of pinkish structure. There's a lot of atypical mitosis here. You can see a lot of atypical mitosis here. And this is not limited to the lower layer of the epidermis. It is all the way to the top basically. So you can see like all the way to the top, I still see all the hyperchromatic nucleus, the pleomorphism, the anaplasia, the presence of mitosis. So when it starts involving the entire thickness of the epidermis, and if it is limited to the epidermis, then it is squamous cell carcinoma in situ. But when this goes to the next stage, it becomes invasive. So when it is limited to the epidermis, the entire atypia, when it is full thickness, that is squamous cell carcinoma in situ. When this atypical keratinocytic nest starts invading the dermis, then it is invasive squamous cell carcinoma. And when it is limited to the lower layer of the epidermis, then that is actinic keratosis. So actinic keratosis is lower layer of the epidermis. Full thickness atypia is squamous cell carcinoma in situ. And then when this atypical keratinocytic nest starts invading the dermis, like you see here, then that is squamous cell carcinoma invasive, where you still see the same atypical features of pleomorphism, anaplasia, atypical mitosis. You see all these atypical mitosis, hyperchromasia. Then you're dealing with a squamous cell carcinoma in situ. So now the variant of squamous cell carcinoma that can sometimes present like this is where the 68-year-old male is presenting with this growing nodule that has this keratin-filled crater. So when you look at this biopsy here, again, there is this big keratin-filled crater that you also see histologically. So again, there is this keratin-filled crater that we see here. And then we also start seeing a little bit of anaplasia here basically. So you can see like there is a little bit of an anaplasia here, where you see the increased NC ratio. The cells have a large amount of cytoplasm. Some of them have a very big nucleus. And then there is this keratinization. But the atypia is not as severe as what you saw in the squamous cell carcinoma invasive. So here you can see that the atypia is quite a bit. Compared to that, this one doesn't have that similar kind of atypia, but again, it is not normal. So you can see this atypia here. This has this crateriform lesion, infiltration into the epidermis, but it is still very well demarcated. So I can see that this is very well demarcated here. And then if I keep looking around, I'm going to see some neutrophilic microabscesses, sorry. Yeah. So if I keep looking around here, I'm going to find neutrophilic microabscesses that are normally seen within the proliferation. So if I keep looking around, there will be neutrophilic and eosinophilic microabscesses within this one. So if you see this kind of a lesion that shows you this very dense filled keratin crater, mildly atypical squamous proliferation that has an infiltrative pattern, there is neutrophilic microabscesses within the epidermis, and this has this very well demarcated border. This is a keratoacanthoma, so which is now described as a well differentiated squamous cell carcinoma. So this is still a squamous cell carcinoma, but this is a keratoacanthoma. This one, and then this one is the squamous cell carcinoma invasive. And then we come to the lesion that we missed here. So this one is another lesion that is 50-year-old male. This, so the other important history, this is very itchy, and the patient has developed a lot of skin nodules because they keep scratching this basically. What has happened is this epidermis here has become quite, so when the patient keeps scratching at the same place all the time, the skin is going to react. And how does the skin react? So first it develops a lot of hyperkeratosis and parakeratosis. Sometimes the granular layer becomes very, very prominent. So the granular layer can be, and then the epidermis becomes very acanthotic. So here you can see that the epidermis becomes very acanthotic, and that there's a very prominent granular layer. And then in the dermis, what we see is what is known as lichenification, where you have this dermal collagen bundles like running perpendicular to the epidermis. So you can see this dermal collagen bundles running perpendicular to the epidermis. But how is this different from the squamous cell carcinoma? If you look at the actual keratinocytes, you don't see that hyperchromasia, that anaplasia, that pleomorphism, that increased mitosis. All that is not there. Like you can see that this nucleus is pretty like normal looking. There is no like angry looking keratinocytes. So this is still like the skin reacting to like some kind of an irritation. So it is proliferating quite a bit. So initially these are termed as lichen simplex chronicus, which is irritation of the skin and then the skin reacting that way. And when it becomes quite intense and it forms a nodule, then it is known as prurigo nodularis. So how is a prurigo nodularis different from a squam? That it does not show the atypia, the cytological atypia that we normally associated with a squamous cell carcinoma. So if you look at the cytology here, the cytology doesn't show the atypia. The architecture is still quite infiltrative looking, but this is more reactive because you don't see any of the cytological atypia that we see either with the keratoacanthoma. So if I go to the keratoacanthoma, I see the cytological atypia here. And when I go to the squamous cell carcinoma, I see a lot of cytological atypia. So that is how you differentiate the prurigo nodularis from a squamous cell carcinoma. Case number 56, 65-year-old man presents with a pearly bump on the upper lip. So when you look at here, this is another very classic case where you see this infiltrative basaloid neoplasm. So you can see that this is a basaloid neoplasm where you see this basaloid cells. So what you see here is this basaloid nest. Very classic features that you see here is what is known as clefting. So this basaloid nest, they separate out from the dermis, and that is known as the clefting here. So you see this clefting here. So one, you see basaloid infiltrative basaloid nest. Second is you see the clefting here. The third you see is this palisade here. So you can see this, there is a layer of the basaloid cells that line the nodule, and that is known as palisading. So you see this palisading here. So basaloid neoplasm with clefting, palisading, and then when you go high power, one very important feature to look for is this apoptosis and mitosis. So you see this apoptotic keratinocytes here. So that is telling you that this is proliferating at a much faster rate. And this is one very important feature to look for because the same basaloid neoplasm can be seen in multiple different cases. Like a trichoepithelioma is going to show you the basaloid neoplasm. A trichoblastoma is going to show you the basaloid neoplasm. A basal cell carcinoma is going to show you the basaloid neoplasm. The clefting can also be seen in a trichoepithelioma. The palisading might also be seen in a trichoepithelioma, but a trichoepithelioma is a benign lesion a basal cell carcinoma is a malignant lesion because it is proliferating at a much faster rate. And because it is proliferating at a much faster rate, we see more mitosis and apoptosis within the basaloid neoplasm. So that is an important feature to look for, the apoptosis and the mitosis within the nest, to like make sure that you're dealing with a basal cell carcinoma. So again, the features: low power basaloid neoplasm, that is one. Second is the clefting 2. Third is the palisading 4. 5 is the presence of apoptosis and mitosis. And then 6 is the stroma. The stroma tends to be a little bit mucinous. And what do we mean by mucinous? It has a bluish tinge to it basically. So a basal cell carcinoma is normally associated with this bluish tinge like stroma here, and that is the myxohyaline stroma. So the term that you are going to read in the books is called myxohyaline stroma basically. So if you see these 6 features, then you know you are dealing with a basal cell carcinoma. Case number 57. So 74-year-old man present enlarging red nodule on the left cheek, and the patient was immunosuppressed and had a kidney transplant. Okay, so now what we see is something very different. So now it is not in the epidermis. So the epidermis looks pretty normal, but there's a lot of action happening in the dermis. So what is happening in the dermis? You go high power and you see this very basaloid kind of again neoplasm that is infiltrating the dermis, but it doesn't show the palisading or the clefting or all of that basically. What you see is a infiltrate of single and nest of basaloid cells. But the other difference here, like if we go back to the basal cell carcinoma here, let's go back here. You can see like these basaloid cells, they still have this pinkish cytoplasm around them. You can see like they have the pink cytoplasm around them. When you go to this one here and you look at these cells here that look basaloid, but there is not too much of cytoplasm here. So it's all like nuclei like collected together. And so it's really not a basaloid cell. What the term that most pathology books are going to use is this is a round blue cell. So you can see that this is a round blue cell with very minimal cytoplasm around it. So it's mostly the nucleus that you see here with very minimal cytoplasm. So this is a round blue cell neoplasm. And if you look at this round blue cell neoplasm, then the chromatin tends to be like what is described as a salt and pepper chromatin. So the salt and pepper chromatin is where you can see like the little bit of a like a dot-like pattern of the chromatin. So here you can see the dot-like pattern of the chromatin, which is known as a salt and pepper chromatin. So this is a round blue cell neoplasm that is infiltrating into the deep dermis. So when it comes to the skin, then you know that you're either dealing with a lymphoma or you are dealing with a Merkel cell carcinoma. Those are the two ones that are going to form this round blue cell neoplasm that is infiltrating into the dermis. So then you do the stains, you do the CK20 stain, and the CK20 is going to show you a dot-like positivity of the Merkel cell carcinoma. So you do the CK20 or you do a P63, which is an epithelial marker, and this will show you positivity with if this is a Merkel cell carcinoma. So the Merkel cell carcinoma is a round blue cell neoplasm that has an infiltrative pattern and just shows these round blue cells with very minimal cytoplasm. And then when you do the CK20 stain or the P63 stain, you're going to see the cells lighting up in a perinuclear dot-like pattern. Case 58. 32-year-old man present with a routine skin check, and then they see this mole. So let's look at so then we know that we are dealing with a pigmented lesion. So this is you can see like there's a proliferation of melanocytes here. So now when you're dealing with a proliferation of melanocytes, like are we dealing with a dysplastic nevus or are we dealing with a more atypical lesion? So what are the features of a dysplastic nevus? The one important feature for to call anything dysplastic is you have these melanocytic nests that are bridging the rete-ridges. So you can see that this is one rete-ridge here, there's another rete-ridge here. So when they start bridging the rete-ridges, that is the feature that you want to look for to call it dysplastic. So remember, when you want to call anything dysplastic, it is not dependent on what you see in the dermis. It is dependent on what you see on the epidermis. In the dermis, a dysplastic nevus always is normal. There is no atypia in the dermis. Everything is is within the epidermis or at the dermal epidermal junction. So all the atypia, dysplasia is going to be seen at the dermal epidermal junction. If I see any melanocytic nest within the dermis, they have to be pretty normal looking when we are dealing with a dysplastic nevus. If they are not normal looking, then I'm not dealing with a dysplastic nevus. So here you can see like all the action is happening at the level of the dermal epidermal junction. So here I can see the bridging. So I know I'm dealing with a dysplastic nevus. And then based on the cytology, I can classify this into mild, moderate or severe. So this one is a severely dysplastic nevus because there's a lot of atypia in the melanocytes that form these nests here. So they are hyperchromatic, they are much larger, they have prominent nucleoli, and they have an increased NC ratio. So when there's like based on the cytology of the melanocytes, I can classify them as mild, moderate, severe. And how do I classify the cytology here? So when I'm looking at the cytology of a melanocyte, one, I'm looking at the size of the melanocyte. Second, I'm looking at the size of the melanocytic nuclei. And third, I'm looking at the shape. So when I'm looking at the shape, are they very similar looking or they have different size and shapes basically? So when we talk about different size and shape, we are talking about pleomorphism or anaplasia. So are they showing pleomorphism and anaplasia? That is one. Second is the size of the melanocyte. Now, how do I compare the size of the melanocyte? I look at a basal keratinocyte. So I just go somewhere where I can easily see a basal keratinocyte. So this is a basal keratinocyte here. So this is the basal keratinocyte. I then compare that to the melanocyte here basically. So this is more than 2 times the size of the melanocyte. And then I look at the nucleus also. So I look at the nucleus, this is quite big. And then there is variation in the size and the shape. So based on that, size of the melanocyte, size of the melanocytic nuclei, the presence of pleomorphism, anaplasia, and the presence of nucleoli, all these features will help me classify the lesion into mild, moderate, or severe. Moving on, this is the next case where we have this lesion where again it is a pigmented lesion. So what do we see here? So here the pigment is mostly in the dermis. So in the dermis, what do we see here is the spindle cell proliferation that shows a ton of pigment in the dermis. So spindle cell melanocytes in the dermis with a lot of pigment is what is termed as the definition for a blue nevus. So these lesions tend to show the Tyndall effect. So they show a little bit of a bluish color of pigmentation in the skin. And then when you do the biopsy, you see the spindle cell melanocytes in the dermis. And if you're not very sure, you can always do the melanase stain or the SOX stain, and all these spindle cells in the dermis will light up. So they will be positive with melanase or SOX stain. And when you can see that, then and with all the associated pigment, you call it blue nevus. So case number 60, a 10-year-old girl, again presenting with a pink bump on her cheek. So what we see here is again another melanocytic proliferation here. But this is a 10-year-old girl. So you have to remember that this is a very young patient. So melanomas are very rare in young patients. It is not that they cannot happen, but they're very rare. So don't jump to the diagnosis of melanoma. So what do we see here? Basically, we see this melanocytic nest here that people have described as banana bodies actually. So you can see like they are like almost like hanging like banana bodies from the epidermis. So that is the first feature. Then when you go and look at these, the other feature that we see here is they are like composed of these very large melanocytes. You can see they are composed of these very large melanocytes, and they have a very big nucleus, and they have also a prominent nucleoli. So you can see the nucleoli. But this is very classic for a Spitz nevus. So a Spitz nevus always shows this very big melanocytes with a big nucleus, increased NC ratio, and very prominent nucleoli. Remember, when we talked about these features where we see a big cell with very big nucleus with prominent nuclei, we said that this was pleomorphism and anaplasia when we talked with other conditions. in the Spitz nevus, this is a normal cytology. So what would be the definition of pleomorphism in a Spitz nevus? So when I start seeing a lot of variation in the size of the melanocyte, like some are these normal large melanocytes, but if I also start seeing smaller melanocytes, spindle cell melanocytes, then I start thinking of atypia. So here we see the spindled and epithelioid melanocytes hanging like banana bodies, and we describe the cytology of the melanocytes. But when you start looking at these at the base, these nests tend to become smaller, and the melanocytes also tend to become a little bit smaller as you go towards the base. So that is another feature that you want to look for. Is there maturation? What do you mean by maturation is that these nests become smaller and the melanocytes also become smaller as they go into the deeper part of the dermis. And then the other feature that you want to look for is that you look at the periphery of the lesion and does it stop abruptly basically. So if it stops abruptly, then that is a good feature. Do I see too much pagetoid spread at the periphery? That's another feature that you want to look for. So this one doesn't show a lot of pagetoid spread in the periphery. So what do we mean by pagetoid spread? Pagetoid spread is the melanocytes that are going above the basal layer. When I start seeing melanocytes either as nest or single melanocytes that start going above the basal layer, that is pagetoid melanocytes. So pagetoid melanocytes is not supposed to be a good feature, but in Spitz nevus again, it is a normal feature. But again, it is normal only when it is present in the middle part of the lesion. If we start seeing a lot of pagetoid melanocytes at the periphery of the lesion, that's not a good sign. So when you talk about a Spitz nevus, either it's a Spitz nevus or it is an atypical Spitz tumor or it is a Spitzoid melanoma. So those are the three categories. This one has this circumscription, so it stops abruptly. There is no pagetoid melanocytes at the periphery. It is maturing pretty well, and there is no like atypical mitosis and all of that. So this is why it's a Spitz nevus. But if it was an atypical Spitz nevus or a Spitzoid melanoma, I would start seeing pagetoid spread at the periphery. This lesion would not stop like abruptly, it would peter off. I would not see the maturation. I would start seeing a lot of mitosis and I would see a lot of pleomorphism and an anaplasia. So, based on all these criteria, I can then decide whether it's a Spitz nevus, an atypical Spitz tumor, or a Spitzoid melanoma. If you need to take a break, just let me know basically. Hello.
Hello, Dr. Rajendra. I think we just continue.
Yep.
Do you want a break for 5 minutes?
We can take a break for 5 minutes. Yep.
Okay, all right.
I just don't want to lose. Like I know, like this is a lot of stuff, so that is the we just. It's better to like do it a little bit.
Maybe we take 10 minutes then. Okay, 5:30.
Okay.
All right.
announcement to all the presenters tomorrow. Kindly upload your PPTs here in the preview desk before leaving today's workshop. Thank you.
Especially those of you who are presenting tomorrow morning, please make sure that you upload your PPTs before leaving. Okay, not to be done now, after the break. The preview desk is here, after the workshop is done.
We should go ahead and start.
Yes, yes, Dr. Rajendra. We can start
Thank
now.
you.
Okay.
Yeah, so case 61. This is an older female, so 59-year-old female with a pigmented lesion again that has become like a little bit more darker. So here's the biopsy here. So here we can see again we are dealing with a pigmented lesion here. So let's look at the lesion here. So now like if you look at this one, this is quite atypical here. So what are the atypical features here? One, like we don't see like just the lesion at the dermal epidermal junction. This melanocytes are also going in the superficial part of the epidermis. So you can see a lot of melanocytes actually going quite a bit to all layers of the epidermis. So this is what is termed as pagetoid spread of the melanocytes. So there's a lot of pagetoid spread of the melanocytes here. There's a lot of proliferation of both single melanocytes as well as nest at the dermal epidermal junction. You can see there's a lot of pleomorphism here where you can start seeing the variation in the size and the shape and the color of the nuclei. And these atypical melanocytes are also infiltrating into the dermis. So you can see a lot of these melanocytes infiltrating into the dermis. So a lot of these melanocytes infiltrating into the dermis. And we talked about the maturation in the Spitz nevi. So here we can see like there is no maturation because even if we go into the deeper part of the dermis, the melanocytes, they do not become smaller. So if you look at the melanocytes on the top and you look at the melanocytes at the bottom, they still are like the big size melanocytes. So there is no maturation of the melanocytes here. So a melanocytic proliferation that is quite extensive. There is a lot of significant pagetoid spread. There's a lot of proliferation at the junction as well as within the epidermis. And there's a lot of melanocytic invasion within the dermis with no maturation in the dermis. So all these features then tend to say that this is more likely a melanoma. So melanoma will show you a lot of pagetoid spread. There is no maturation of the dermal component, and then there is a lot of atypia and pleomorphism of the dermal component. So if you see all these features, then you start thinking that most likely you're dealing with a melanoma. The other thing that also you can see here that this tends to like keep going on at the periphery. It doesn't stop like we saw in the one that was there was like a nest that stopped. It keeps like petering out in the periphery. All these single melanocytes keep petering out in the periphery. There's significant pagetoid spread and all of those features. And then obviously if I do a Ki67, I might see some increased Ki67 here. If I do the melanase stain, it will show me the pagetoid melanocytes. So sometimes to like highlight them, we do the melanase stain. And then if I do an HMB45 stain, yeah, most of the times in a melanoma, the HMB45 will stain the entire dermal component. And if this was a benign nevus, then it will only stain the superficial part. In a melanoma, it tends to stain the entire component actually. So all these features should help you make the diagnosis: significant pagetoid spread, no maturation of the dermal component, and the significant pleomorphism atypia should help you make the diagnosis of a melanoma. 72-year-old man present with a firmly non-pigmented nodule on his left temple. So now this was a nodule on the left temple. So what do we have here basically? So one, it was an older patient and this was on the head and neck area. And this is a very subtle lesion. Many times it has been misdiagnosed as a scar because it looks very scar-like here. So you can see like it looks very scar-like here. And many of the times it gets misdiagnosed as a scar. But if you start looking at it carefully, there is a spindle cell proliferation here. Like what we can see, there is a spindle cell proliferation here. So there is quite a bit of a spindle cell proliferation. So these are the spindle cells that you see in the dermis here. So all these are spindle cells that you see in the dermis with this elongated nuclei. So these are all the spindle cells in the dermis. So there is a significant spindle cell proliferation, and it is quite infiltrated because even if I go at the base of the subcutaneous fat, I can still see the spindle cells here basically. So it's not only limited to the dermis, it's an infiltrative spindle cell proliferation. Now, when it is an infiltrated spindle cell proliferation, I have to definitely think of sarcoma or something like that, like it is a soft tissue neoplasm. But also, like, better to go and look at the epidermis here. And what do we see in the epidermis? We see a lot of melanocytic proliferation in the epidermis also. So now I see a lot of melanocytic proliferation in the epidermis, and then I see the spindle cell proliferation in the dermis that looks like a scar and is quite infiltrative. So definitely I have to start thinking of desmoplastic melanoma. So I then do the S100 stain, and the desmoplastic melanoma will like stain very positively with the S100 stain. So when all the spindle cell will be positive, and then I know I'm dealing with a desmoplastic melanoma. So like if you see a spindle cell proliferation in the dermis that looks like a scar that is quite infiltrative, and if you're lucky and you see the melanocytic proliferation in the epidermis, then the diagnosis is very easy. That most likely you're dealing with a desmoplastic melanoma. But 50% of cases of desmoplastic melanoma do not show an epidermal component. It only shows the spindle cell component in the dermis. So at that time, if you're not thinking about it, you're going to miss the diagnosis. So if you start thinking, then you do the stain, and then that should help you out. Like the S100 positivity will help you out in making the diagnosis. 68-year-old woman present with a persistent itchy rash in the groin. So this is like a rash in the groin that the patient has. So let's look at the biopsy here. So what do we see here is there is a lot of proliferation in the epidermis. So like there's a ton of proliferation that is happening in the epidermis here. So we know we are dealing with some kind of a malignant lesion. It's not a rash. There's some kind of an atypical lesion going on here, which is predominantly intraepidermal. So when it comes to predominantly intraepidermal, like what could it be? Either it's a squamous cell carcinoma, or it's a melanoma in situ, or it is something else. So like if you'll start looking at this here carefully, like most of the keratinocytes that you'll see here, they don't have the atypia here. Like it is more, they are pretty normal here. So that is very unlikely. But definitely we'll still have to do the stain to rule it out. The melanoma in situ tend to normally stay at the base, and then you see pagetoid spread, but this is like filling up the entire epidermis. So again, less likely, but again we will have to do the stain to rule it out. So we do the P63 stain, which is a keratinocytic marker or an epithelial marker, and it could be positive, and then we do the S100 and melanA, which is going to be negative. So that rules out the melanA negative and the S100 negative. They rule out the melanoma in situ, or even like some sort of a Langerhans cell problem basically. So then like this is a lesion in the groin basically. So we have to always think of extramammary Paget's disease. So when we start looking at this more carefully with that thinking cap that this could be extramammary Paget's, then it actually fits the bill, because you start seeing these large cells throughout the epidermis that have this very large amount of cytoplasm. They have a very prominent nucleoli, and that is very, very characteristic of extramammary Paget's disease. Then we do the CK7, the CK20, the CM, EMA, and the CEA. And if those are positive, then we know that we are dealing with an extramammary Paget's disease. That tends to be positive for CK7. It tends to be positive for EMA. It tends to be positive for CAM 5.2. Those are the markers. And these are normally negative, like the CAM 5.2 and the EMA are normally negative in squamous cell carcinoma. So like you will do a battery of stains to first rule out a squamous cell carcinoma. You will do a battery of stain to rule out melanoma in situ, and then the other stains to prove that this is extramammary Paget's. So histologically, it is very difficult to just make the diagnosis based on the histology. You can be suspicious, but then the immunohistochemistry is what will help you make the diagnosis and differentiate this from a squamous cell carcinoma in situ or a melanoma in situ. So 12-year-old girl is presented to the clinic with a firm lump on her cheek. So here is the lump that we see here. So this is like a big nodule that you see in the dermis. So this is a nodule in the dermis. So it's a nodular proliferation, which is composed of these very like pink hyaline like this. You can see like this is like all these pink structures here. So when you go high power and you start looking at this pink structure, you see that these are actually keratinocytes that are like becoming necrotic. And so you can see the outline is still preserved, but the nucleus is gone basically. And the term that is being described is these are ghost cells. So these are like what has been described as ghost cells, which are keratinocytes that are like going that are becoming necrotic. So they still retain their outline, but they have lost their cytoplasm and as well as the nucleus. So they are just like the ghost is remaining there, and the cell is dead. So these are termed as ghost cells. So you see this nest of ghost cells here, and then you will also see a proliferation of this basaloid cells here. So these basaloid cells they proliferate very quickly, and because they proliferate very quickly, you will see a lot of mitosis with them. So that is a normal part of the lesion, and because they proliferate so fast that they become necrotic, and they then tend to become the ghost cells basically. So you see this proliferative basaloid nest with these associated ghost cells, and this necrotic keratinocytes they will extrude the keratin, so they release keratin, and because they release the keratin, you will also see a giant cell foreign body reaction here. So the foreign body reaction is in the form of giant cells, macrophages, and all of that. So that foreign body reaction is in release of the keratin from these ghost cells. So a nodular proliferation composed of ghost cells, basaloid nest with significant proliferation, and a lot of foreign body reaction. All of these features, younger patient, this is a pilometric coma. So pilometric coma tends to show you this kind of histology. 35-year-old woman present with multiple small form skin colored papules. So here is the skin colored papule. So again a basaloid neoplasm. Remember we saw the basal cell carcinoma where we had the basaloid nests. So again we see the basaloid nest here, where you see this large nucleus with very minimal cytoplasm. But there is some cytoplasm here. So this is a basaloid neoplasm. So again, like the first thing to always think of is, am I dealing with a basal cell carcinoma? So do I see the clefting? I might see the clefting in this one, but this like somewhere I might see the clefting here. Do I see the peripheral palisading? There is some kind of a palisading here. Then if I go to the nest, do I see apoptosis and mitosis? So this one doesn't have the apoptosis and the mitosis. So it has the basaloid nest. It could sometimes show the clefting. It might show the palisading, but it doesn't have the apoptosis and mitosis that we normally associate with the BCC. And the stroma also is a little bit more pinkish. Like remember we talked about the myxohyaline stroma in a basal cell carcinoma, more bluish kind of stroma. This one is more fibrotic stroma. So this one has a more fibrotic or a pinkish kind of stroma. It doesn't have that bluish tinge. It doesn't have the apoptosis. It doesn't have the mitosis. Then the other characteristic feature that we see here is this here basically. So this is like the base of the hair follicle. Like if you look at a hair follicle, like it tends to have this base where it will the dermis is going within the base of the hair follicle. So this base of the hair follicle, we will look at this again in another biopsy just to reiterate this feature. This is known as a papillary mesenchymal body. So this is known as a papillary mesenchymal body. So the presence of basaloid nest with peripheral palisading, some may be clefting present but usually absent, no apoptosis, no mitosis, no myxohyaline stroma, more of a fibrotic pinkish stroma, with the presence of papillary mesenchymal bodies, which is the base of the hair follicle. These are all features that will help you make the diagnosis of a trichoepithelioma. So this is a tricho means a hair follicle lesion. So hair follicle, and this is the reason the papillary mesenchymal bodies that you see here, because that's the base of the hair follicle. So trichoepithelioma. A 32-year-old man present with a slowly growing, enlarging, painful lump on the upper back. So this is like a recent lesion. A very classic cyst here. Like this is a circular lesion that you see here. That has this lining, epithelial lining here. So when you see a structure that is a circular structure with an epithelial lining, you call it a cyst. So, and then based on the lining of the cyst, you can then classify the cyst. So this one has a lining that looks very similar to the epidermis. So if you look at the epidermis here, this lining that you see here is very similar to the epidermis, and you go high power and you will see all the granular layer and everything here within the lining. So this is a feature of an epidermoid cyst, like a cystic structure with a lining that looks very similar to the epidermis. Some people also call it a follicular inclusion cyst or epidermoid cyst, whatever you like the name. You can call them either follicular cyst or epidermal inclusion cyst. 28-year-old woman presents with multiple small firm skin colored papules on the cheek. So another very classic lesion where you see again these cystic structures within the skin. But these are not that big cysts, these are multiple cystic structures. So these are, so when you go high power, you can see that these are lined by this two layers of cells. So these are actually glands. These are not the cystic structures, these are actually glandular structures because they have this eccrine gland like lining here. So two cell, one is the round cell here you see here and the peripheral. So these are glands basically. So these are collection of glandular structures that you see here, and some of them they tend to look like a tadpole. So like if you did like this is a round cell and then this is the tail here. So they are these tadpole like cells. Again this is a tadpole here where you have this round cell here and then the tail here. Again the round cell here and the tail here. So glandular structures with tadpole like background having two layers of cells, like one is the outer layer and one is the inner layer, and then they have this eccrine secretions in the center. So this is an eccrine neoplasm. So these are eccrine ducts that are proliferating, and the term that we use for them is a syringoma. So syringoma tend to occur like multiple lesions either around or under the eyes, or they can sometimes occur in the groin area. And they tend to show this glandular collection of glandular structures with tadpole like say like features like the with the tail and all of that. So if you see that, and you can see the duct lining here. So you can see that there's a duct lining here, another duct lining here. So you know you're dealing with the glandular structure. So this is a syringoma. A 45-year-old woman presents with a painless growing mass near the left jawline. It's non-tender. So another classic lesion here where you see a little bit of a biphasic structure. But what do we mean by biphasic? Is one, you have the epithelial component here. Epithelial means like you have the some structure that has epithelial like look to it. So either it is coming from the eccrine glands, or it is coming from the epidermis, or it is coming from the apocrine glands or something like that. So you have this epithelial structure here. And then the other part is the stromal structure here, which is a little bit cartilaginous. So it looks like a little bit of a cartilage. So you can see like it has that bluish tinge like a cartilage. So there are two components, biphasic, two components. One is the epithelial component and the other is the stromal component. So and this epithelial component can be either nest or it could be glands or tubules here. So here you can see like it is forming like a gland here basically, where you have the cyst here central, and then this is surrounded by the epithelial cells, another glandular structure here. So this is more tubular, this is glandular, another glandular structure here, and then you have the solid area. So this is a solid area. So this is a solid area, glandular area, and then the tubular area. So you have this, and then you have the cartilaginous areas basically. So you can also see the cartilaginous areas here. So this is a biphasic tumor. So because of the biphasic tumor, it is called a mixed tumor. That is the term that is used, and the other scientific name is chondroid syringoma. Chondroid means cartilaginous. So cartilaginous syringoma, that's what it is. The other term, very easy to remember, is the mixed tumor because it is a mixture of two elements, epithelial and stromal elements basically. The other term that is used is epithelial and mesenchymal elements. Mesenchyme is the stromal part. 55-year-old man presents with a slowly enlarging bump on the sole of his foot. Here is the bump on the acral site. So here again you can see like this is the normal epidermis here, and then this is another kind of proliferation that looks a little bit different from the normal epidermis. So if you look at this color here and you look at this color here, this is different. So this is a proliferation of something different that is happening here. and that is very well seen at the periphery of the lesion. So if I go at the periphery of the lesion here, you can see like this is the normal epidermis. So there's like a kind of a sharp demarcation. If I go here again, you can see there's like a sharp demarcation like we saw in the clear cell acanthoma. But this is not like a clear cell basically. The pattern is not of a clear cell. And then if I start looking around here, so there is a proliferation of this kind of acanthotic epidermis, and then with a very sharp demarcation at the periphery. The other characteristic feature is when you look at the stroma here, there tends to be a lot of vessels in the stroma. So the stroma tends to show you a lot of vessels, and people call it a granulation tissue like stroma. So in granulation tissue, you see a lot of stroma. So this is like a granulation tissue like stroma. And then the other feature that we will see, like if you look around very carefully, there will be some scattered ducts basically, because this is an eccrine neoplasm. So here is the duct here that you see here. So this is a duct here. So this is the eccrine gland that is started to proliferate. So you will see scattered ducts, and sometimes we do an immunostain to find the duct. So the ductal lining can be highlighted by a stain called CEA. So if you don't see the duct, you can do a CEA and it can find you the ductal lining basically. So this is actually an eccrine neoplasm or sometimes also an apocrine neoplasm, that shows this proliferation within the epidermis. It can sometimes also go into the dermis. And this shows this very sharp demarcation from the epidermis, admixed ducts, and then the granulation tissue like stroma. So combination of these features will help you make the diagnosis of a poroma. Poroma is another adnexal neoplasm that arises from the eccrine or the apocrine ducts. This is another adnexal neoplasm that we see here that is a little bit different from the poroma. It still shows you the basaloid proliferation here, but then it has this solid pattern and then it has the cystic pattern. So you have the solid and the cystic pattern. And then when you go into the solid areas, it's again composed of these basaloid cells, and then there are scattered ducts again. But you can see this lining here. This is the scattered duct here. So again, we know that this is an eccrine or an apocrine neoplasm that shows this basaloid kind of proliferation. And then focally it also shows this very sclerotic dermis. Like you can see like this dermis is very, very sclerotic. So this is another feature that you want to look for. So sclerotic dermis, basaloid neoplasm, some of these cells could sometimes even show a clear cell basically. So if I go and look carefully here, you will see like some of them show me a clear cytoplasm. So some of them have a clear cytoplasm. Some of them have a basaloid cytoplasm. So this is another feature. There is a little bit of mucin. Some can show a myxoid kind of cytoplasm. So there is a mixture of all these cells. There are admixed ducts here. So if I go and then there is this very sclerotic stroma. So if you see a combination of all these features, so solid and cystic basaloid neoplasm, which is solid and cystic, and there is a little bit of mucin, with some basaloid cells, some clear cells, and then also admixed ducts here. Then that is what this very sclerotic combination makes the diagnosis of hydroadenoma. Solid and cystic, another adnexal neoplasm, which is termed as hydroadenoma, which is in the same family as the poroma and the hydroadenoma, and then also admixed ducts. Then that moving on to the next adnexal neoplasm. This was on the upper arm that has been present for several months. So another adnexal neoplasm. So the way to describe this one, like to remember, this one is blue balls in the dermis. So you can see that this is a blue ball here. Moving on to the another blue ball here. This is another blue ball here. So when you see this blue balls in the dermis, so you have to start thinking of the adnexal neoplasm that this one is blue balls in the dermis. So if I go high power into the blue ball here. This is another blue ball. What is it composed of? Another blue ball here. So when you see this blue composed of this, you have to start again like a basaloid neoplasm that this one is basically with scattered lymphocytes. So you see all these lymphocytes are sprinkling throughout the lesion. You see a lot of sprinkled lymphocytes throughout the lesion. Again like a basaloid. And then focally there is this increased basement membrane material, like pink material that we see within the nodule. Lymphocytes throughout the lesion. So this blue balls in the dermis composed of these basaloid and pale cells with a lot of lymphocytic sprinkling. All this combination should help you make the diagnosis of a spiroadenoma. So that is a spiroadenoma where you see these blue balls in the dermis. All this combination should help you make the diagnosis of a spiroadenoma. This is another classic adnexal neoplasm that we see here. So this is present on the scalp. So what we see here is nice exophytic and an endophytic growth pattern. And the endophytic growth pattern tends to show you this papillae, and an endophytic growth papillae is like, and the endophytic growth pattern, remember in the cyst you had that empty space surrounded by the epithelial cells. In a papillae, there is not an empty space, but there is a fibrovascular core. In a papillae, there is a fibrovascular core that is surrounded by these epithelial cells. So in this classic lesion, what we see here is a exophytic and an endophytic proliferation, showing this fibrovascular core papillae. And within the fibrovascular core, if I go high power, you can see there is a party of plasma cells going on. So you can see the going on. So you can eccentric nucleus, and then the cytoplasm that shows you this saddle-like hoof, like the hoof of the foot of the horse. You put the saddle, and that saddle has this horseshoe shaped. So this one has this horseshoe shaped of more dark looking thing basically, and that is what defines a plasma cell. The plasma cell has this nucleus that is pushed to the periphery, and the cytoplasm will show you this hoof. That is the hoof of the foot of the horse. So there is a party of plasma cell going on within the fibrovascular core of the dermal papillae. So whenever you see this endophytic and exophytic proliferation with dermal papillae that show plasma cells, a large number of plasma cells in the dermal papillae, then the diagnosis is going to be syringocystadenoma papilliforme. That's another ethnic cell neoplasm, but that shows these very classic features of plasma cells having a big party within the fibrovascular core of the dermal papillae in the endophytic proliferation. So case 73, keeping on the same chapter, this is another nodule that the patient developed on the upper lip. But this one now is a little bit different than what we have seen previously. So what do we see here? This is a proliferation that is quite infiltrative actually. So it is going quite into the deep part of the dermis. You can see like this proliferation keeps going on in the deep part of the dermis. Now what is this proliferation composed of? So if you look at the top, it has these keratocysts here. So keratocysts are this cystic structures that have this epithelial lining as well as the keratin material within them. So when you see this keratin material within them, this is known as a keratocyst. So you see this keratocyst on the top with some basaloid nests. So these are the basaloid nests here that have an infiltrative pattern. And these infiltrative basaloid nests, as you go to the base of the lesion, they tend to become quite smaller. So there's a lot of space, like at the base they are tend to become smaller, but they are still that basaloid. So it's a basaloid neoplasm which is very infiltrative, that has this keratocyst on the top. And then if I keep looking around, I'll see some perineural invasion also in this lesion. So if I keep looking around, I'll find some perineural invasion. So that's another characteristic feature. And then the stroma, if you look at the stroma, it is very pinkish. It's a very sclerotic basically. So a very sclerotic stroma. So infiltrative neoplasm that is composed of keratocyst on the top, and this basaloid infiltration to the base of the lesion in a very sclerotic stroma, and some perineural invasion. And if I go and look at the actual basaloid cells, I don't see too much of cytological atypia. So these tend to lack cytological atypia, but they are very infiltrative and they go into the deep part of the dermis. So when you see a combination of all these features, where you see the keratocyst, the basaloid nest infiltrating into the deep part of the dermis without too much of cytological atypia, then the diagnosis is microcystic adnexal carcinoma, which is also called a MAC, microcystic adnexal carcinoma. Case 74. So this one is a 67-year-old present with a yellowish nodule on the left cheek. So again another adnexal neoplasm, but now we are moving on to another category. What is the category? Here you can see like these are this is composed of a lot of these clear cells. And what are these clear cells? When you go high power, you can see this clear cells show a lot of compartmentalization. So you can see these are compartments here. So whenever you see a large clear cell
with a lot of
compartmentalization, that is the sebocyte. So that is part of the sebaceous structure that you see in the
So the
skin.
next time you go
So
and
the
look
next
at
time you go and look at the sebaceous structure, go high power. And if you go high power and you actually look at the sebocytes,
you will see this
you will see this compartmentalization of the cytoplasm.
and that tells you that
you are dealing with a sebocyte.
So this is a
neoplasm of the sebocytes.
So now when you
So now when you're dealing with the neoplasm of the sebocytes, you are either dealing with a sebaceous adenoma,
you are dealing with
sebaceous hyperplasia,
sebaceous
sebaceous epithelioma, and then the fourth one is sebaceous carcinoma. There are only four lesions basically. One is sebaceous hyperplasia.
The other is the
sebaceous adenoma.
The third one is
The third one is the sebaceous, and some people call it the sebaceous epithelioma. You can remember any one of them.
And then the fourth one
is sebaceous carcinoma.
So how do you differentiate
between the four of them?
So in a sebaceous
hyperplasia, you only see the proliferation of the sebocytes. You don't see this admixed basaloid cells. Here you also see admixed basaloid cells.
So these are the basaloid
cells.
They see the admixed
proliferation.
Here is another basaloid
cell nest that you see here. They see basaloid cells and the sebocytes.
So when it is only
a
proliferation
of the sebocytes, then it is sebaceous hyperplasia.
I don't see
a lot of basaloid cells in a sebaceous hyperplasia.
When I start seeing
a lot of basaloid cells admixed with the sebocytes,
but the sebocytes
are still more than 50% of the lesion.
Here you can see like the
basaloid cells are there, but they are less than 50% of the lesion.
And there are more
sebocytes, then it is a sebaceous adenoma.
If it was a similar
lesion but showed more basaloid cells than the sebocytes, so if the basaloid cells are more than 50%,
then we call it a
sebaceous epithelioma. And epithelioma means it is composed more of epithelial cells. So the basaloid cells are epithelial cells. Because it's more epithelial cells than the sebocytes, it is a sebaceous epithelium.
If
it is more sebocytes than the basaloid cells, then it is a sebaceous adenoma. Adenoma is a collection of glands.
Collection of cells.
So sebaceous adenoma.
And if it is only
sebocytes and no basaloid cells, then it is a sebaceous hyperplasia.
And then if
the
atypia becomes
atypical, here you can see like the atypia of the sebocytes.
So here again,
these are sebocytes. If I go high power, I can see that they have this compartmentalization of the cytoplasm.
So I can still see that
this is composed of sebocytes here. So this is the cytoplasm here that has the compartmentalization.
So again, I'm still
dealing with the sebaceous neoplasm. But here there's a lot of atypia. You can see like these are hyperchromatic nucleus. There is a lot of pleomorphism. There is anaplasia. And a lot of atypia compared to the normal sebaceous adenoma or the epithelioma or the hyperplasia. There's a lot of basaloid cells that mix, and there's a lot of atypia and pleomorphism. So when I start seeing a lot of atypia and pleomorphism, then I'm dealing with a sebaceous carcinoma. Sebaceous hyperplasia,
then comes the adenoma,
then comes the epithelioma, and then comes the sebaceous carcinoma. The carcinoma is atypical with pleomorphism and anaplasia, and then the sebaceous adenoma tends to have more sebocytes, the epithelioma tends to have more basaloid cells, and the sebaceous hyperplasia is only sebocytes.
Case number 76.
So now we are moving away from the adnexal neoplasm.
So this one is a
soft tissue neoplasm that shows this buttonhole, positive buttonhole sign.
So this one is a
spindle cell proliferation. So now we are moving into the spindle cells within the dermis that can cause a different kind of lesion. So what are the structures in the dermis that can cause neoplasms?
So you can have a
blood vessel neoplasm. You could have like a fibroblastic neoplasm. You could have a neural neoplasm.
Those are the structures
that we normally see in the skin. In the skin, if you look at the dermis, there are nerve bundles, there are blood vessels, the fibroblasts within the dermis. So you could have a fibroblastic proliferation, you could have a vascular proliferation, you could have neural proliferation. And then there are other proliferations. So when it is a neural or you could have a proliferation of the fat. So the proliferation of the fat is the lipoma.
When it is a neural
neoplasm,
and so you could have like
either a neurofibroma. So a neurofibroma is neural proliferation. So this one is a neurofibroma, where you can see this proliferation of this neural cells.
that neural cells
tend to be
a little bit wavy
nucleus. So if you look at this nuclei, they tend to be a little bit like a wave.
So you see
a
spindle cell
proliferation in the dermis,
having this like kind of a
myxoid
or a
bluish background.
and then when you go
high power, you see this wavy nuclei. And
it's quite monotonous.
It doesn't have like cellular and hypocellular areas. It is very monotonous.
So if you see this, then
you are going to call this a neurofibroma.
Compared to this one, case 77
is again a nodule, but again this is spindle cell.
Here you can see like this is
again a spindle cell proliferation.
But this one tends to have cellular areas
and then hypocellular areas.
So again a neural
neoplasm, but has very cellular and then some hypocellular area. In the books they are described as Antony type A and Antony type B.
So when you have this
hypercellular and hypocellular areas in the neural neoplasm,
that is the
feature of a schwannoma. If they just tend to have like a very bland looking neural neoplasm, that is a neurofibroma.
Case 78
is still sticking to the neural neoplasm,
but this one tends to be more
epithelioid looking.
So this one has a more
epithelioid looking cytoplasm, which is very granular.
And then they tend to have
a very pycnotic nucleus. So a nodular proliferation in the dermis
that is composed of these
large cells.
And they have a very
granular kind of cytoplasm. You can see this is a granular kind of cytoplasm.
And they have this
small round nucleus.
And this granular
type of cytoplasm is what gives it the name granular cell tumor.
The granular cell
tumor tends to present with this
nodular
proliferation in the dermis.
And there's
individual cells, they have a large amount of granular cytoplasm.
Case 79.
Now
we are moving to the
fibroblastic proliferation. So that was the neural proliferation.
Now we are moving to the
fibroblastic proliferation. Fibroblasts, if you look at the normal skin,
you have these scattered
cells in the dermis, like all these spindle cells in the dermis, that are the fibroblasts.
So this very scattered,
very rare kind of cells that you see here.
These are the fibroblasts.
And the fibroblasts tend to have this
rice grain
like kind of nucleus. Like if you look at the nucleus of a fibroblast,
it is rice grain so
that it is tapering at the two ends. So that is one structure.
If you look at a neural,
this is a nerve here that has the wavy nucleus. So that is the wavy nucleus that helps to tell. Then you have the smooth muscle bundle. If you look at a smooth muscle bundle here,
so this is a smooth muscle
bundle.
They tend to have
this nucleus that is a little bit cigar shaped and it's blunt end at the two sides.
And they also tend to
have a lot of pinkish cytoplasm. So if you look at a nerve bundle, the smooth muscle bundle, which is the pilar muscle,
they have this
cigar-shaped nuclei with a large amount of cytoplasm.
So that can proliferate
and cause a leiomyoma.
The fibroblasts
can proliferate and they can cause fibroblastic proliferation.
The nerves can
proliferate and they can form a neural neoplasm.
The blood vessels can
proliferate and they can form a vascular proliferation.
And then the
lipocytes can proliferate and they can form a lipocytic proliferation.
And you already saw
this is a normal kind of sepocyte. Again, the vascularization or the compartmentalization of the sepocytes. So
when these
fibroblasts start to proliferate,
the most common
region that you see here is here. So this is a fibroblastic proliferation, where you see this collection of fibroblasts that have started proliferating and forming like a nodule in the dermis.
So this is a nodule
of fibroblastic proliferation. There is not too much of atypia, so I don't see any mitosis, pleomorphism, anaplasia, which we already talked about. What is pleomorphism, what is anaplasia? We don't see that here.
So this proliferation
in the dermis, and then the other feature of a fibroblast, and then the other feature you see this collagen entrapment. So this collagen gets entrapped within the fibroblastic proliferation. So when you see this spindle cell proliferation with collagen entrapment and no atypia, this is a very classic lesion, dermatofibroma. And the similar lesion that is fibroblastic, but now is very infiltrative. So here you can see this is a fibroblastic proliferation, but this is very infiltrative. So if I go high power, I can still see the rice grain kind of nuclei with very little cytoplasm, but then very infiltrated. And it almost forms like a honeycomb pattern with the fat. So if I go low power, this is termed as a honeycomb pattern of the fat. So you have a spindle cell proliferation that doesn't show any type of cytological atypia, but has a very infiltrative pattern. It goes into the deep dermis and also goes into the reticular dermis, so like into the fat. I can see that proliferation also extending into the fat. So same proliferation extending into the fat. So very proliferative lesion with this honeycombing pattern. So this is very classic for a DFSP, which is dermatofibrosarcoma protuberans. And this will stain very strongly with a stain called CD34. So if I do a CD34, it will light up the entire lesion. But this infiltrative pattern and the honeycomb should give you the diagnosis of a DFSP. Case number 81, another spindle cell proliferation here. Here you can see again we have the spindle cell proliferation. So all the spindle cells here, but again there is a lot of atypia here because I can see hyperchromasia, I can see variation in the size and shape of the nucleus, I can see these mitosis, you can see the scattered mitosis here. So there is atypical mitosis, there are some epithelioid cells, there are spindle cells, so there is a lot of pleomorphism. So here what I see is a atypical spindle cell proliferation that is abutting the epidermis. I can see like this is like almost like going to the epidermis. The other term that people use is slamming the epidermis. Why is that word you slam? Slamming the epidermis because that gives you the differential diagnosis. So slamming is SLAM. S means a spindle cell. S is the spindle cell squamous cell carcinoma. L is the leiomyosarcoma. A is the atypical fibroxanthoma, and 4 is the melanoma. So SLAM is the differential diagnosis for an atypical spindle cell proliferation that is slamming the epidermis. So if it is atypical and is slamming the epidermis, I need to rule out melanoma. So I do the S100 stain. If it is a melanoma, it will stain positive, and then I know I am dealing with a melanoma. If it is a spindle cell squamous cell carcinoma, I can do an epithelial marker like a P63. If it is positive or P63, then I know that I am dealing with the spindle cell squamous cell carcinoma. If it is L, which is the leiomyosarcoma, it is going to stain with a desmin. So I do a desmin stain, and then if it is positive, then it is a leiomyosarcoma. And if all of these are negative, like S100 negative ruling out the melanoma, the P63 negative ruling out the squamous cell carcinoma, the desmin is negative ruling out the leiomyosarcoma, then the atypical fibroxanthoma AFX is the diagnosis of exclusion. I rule out everything else, and then I can call this an atypical fibroxanthoma. This will be positive for one of the markers is CD10, but CD10 can also stain a melanoma sometimes. So you cannot use it to rule out a melanoma. So that is the reason we do it, just for the sake of showing something positive. But that doesn't make it an AFX. AFX is more of diagnosis of exclusion because this was S100 negative. So that was the reason I ruled out the AFX. Ruled out the melanoma. So once I rule everything out, then I call this an atypical fibroxanthoma. Case number 82. This was a painful lesion. So this is another giveaway sign that this is a painful lesion under the nail bed, and it was tender to touch basically. here we see a vascular proliferation. So now we are moving into the vascular proliferation. Where this is a vascular proliferation, so you can see a lot of blood vessels here. But then this vascular proliferation has these round cells that are surrounding it basically. These round blue cells that are surrounding the vascular proliferation. So this is very classic for a glomus tumor. In a glomus tumor, you see these round blue cells that are very monotonous looking. So these are all monotonous looking round blue cells that surround the blood vessels. And then if you see that, then that is a glomus tumor. Case number 83. So this is another spindle cell proliferation. So you can see like this is spindle cell. So remember, like we talked about the cigar shape of the nuclei and a large amount of cytoplasm. The fibroblasts, they don't have this large amount of cytoplasm. This one is a large amount of cytoplasm and has the cigar shape, so the blunt end of the nuclei. When you see that and you see this proliferation of spindle cells that are running in fascicles, then you know you are dealing with a smooth muscle proliferation. So then you start looking for any atypia, mitosis, pleomorphism, necrosis. If you don't see all of that and you see this proliferation of smooth muscle bundles, you can use a Desmond stain to prove it out, but many of the times it is not needed. But if you are not sure, you could do the Desmond stain, it is going to be positive, and then you know that you are dealing with a leiomyoma. Compare that to this one. Again, it's the same kind of proliferation, where you see the spindle cell with a large amount of cytoplasm. But here you can see there's a lot of variation in the nuclear size and the shape. And if I look very carefully around, I'm going to see a lot of mitosis in this one. This one has the same smooth muscle proliferation, but then the lesion tends to have a little bit of a pleomorphism, little bit of scattered mitosis, and this is also quite infiltrative. If I go low power, I can see like it's going quite deep into the dermis basically. I can see the nodules going into the dermis, and if I go and look at the nodules, they will show me a lot of mitosis. I can do a Ki67 which will show me higher proliferation, and then I can call it a leiomyosarcoma. Leiomyoma and leiomyosarcoma look very similar, but there is more atypia, mitosis, pleomorphism in the leiomyosarcoma compared to that seen in a leiomyoma. Case number 85. This is a younger patient. So very young patient. These are lesions that I see in front of the right ear. When I look at them, they are polypoid lesion that has the cartilage here. So you can see the cartilage here, the fibrofatty tissue here, and then very small villous hairs. A lot of large villous hairs here. So these are very small hair follicles here. A lot of villous hairs, fibrovascular core, and then this cartilage. So this is an accessory tragus, basically that tends to occur in younger patients around the ears. Case number 86. So vascular neoplasm. You can see a lot of blood vessels here. So a lot of blood vessels here. You can see them here. So it is a collection of blood vessels. And they are forming lobules. So this could be called a lobular capillary hemangioma or just a capillary hemangioma. A collection of blood vessels is hemangioma. So this one is lobular. So it is called a lobular capillary hemangioma. You can see there is not too much of atypia. What does atypia mean in a vascular neoplasm? Is these cells that line the blood vessels, they are called endothelial cells. So these lesser vessels, that line the blood vessels, are called endothelial cells. So in a benign vascular proliferation, the endothelial cells is a single layer. It is always a single layer of cells. When they start multiplying, then it is an atypical vascular proliferation. So if I start seeing a lot of endothelial cells forming multiple layers, forming solid areas, then I start thinking of atypia within a vascular neoplasm. So here is another vascular neoplasm, but this is composed of spindle cells. So if I go high power, I can see that this is a vascular neoplasm because there is a lot of blood vessels associated with the hemorrhage. But then there is an associated spindle cell proliferation. If I look at this, there is a spindle cell proliferation that is associated with a lot of hemorrhage. If I go back to the history, This is a patient that was HIV positive. There are multiple violations, patches, plaques, and nodules, which show this very hemorrhagic proliferation that has a lot of blood vessels and is associated with the spindle cell proliferation. So if I see this, then I'm going to start thinking of Kaposi sarcoma. I do the HHV8 stain, and it is going to light up all the spindle cells in the dermis. So the spindle cells, they are around blood vessels. If I see a lot of blood vessels and the spindle cells in a patient that is immunocompromised, maybe HIV, maybe something else, then I start thinking of Kaposi sarcoma. I do the HHV8 stain, and it should light up the entire lesion basically. Compared to that, this one is again another vascular proliferation. I can see like there is a lot of vessels here. All these are blood vessels here. You can see this is blood vessel here. But now if I look at this proliferation, the endothelial cells are not only plump and large, they are also forming like a infiltrative pattern, and some of them are multiple layers. So you can see like there are multiple layers within the endothelial cells. So infiltrative pattern, a lot of endothelial cells that are forming some solid areas, and you can see like the solid areas here. Some of them have multi-layering. There's a lot of atypia and pleomorphism here, with a very infiltrative pattern of the vascular neoplasm. So these are all vessels that are going deep into the reticular dermis. So these vessels are all proliferating and going into the deeper dermis. Some of these books describe like this as a cracked collagen pattern. It's because it looks like it is cracking through the collagen and then infiltrating the deeper part of the dermis. And if you are not sure, then you can always do the marker for endothelial cells, so CD31 or an ERG are cells that are markers that will highlight endothelial cells. Endothelial cells are cells that are lining the blood vessels. So if you do a CD31 on an ERG, it is going to highlight all these solid nest of cells that I see within the dermis with this vascular proliferation. So I know this is a proliferation of endothelial cells that is infiltrating the dermis. So the diagnosis then becomes angiosarcoma, because it's a sarcoma developing from the angioma and the vessels basically. Case number 89. Now we are moving towards the lymphomas basically. So there are lymphomas can also occur on the skin, and the most common lymphoma 90% of the time is a mycosis fungoides. So what do we see in a mycosis fungoides? Mycosis fungoides tends to show a lot of lymphocytic exocytosis. So you can see like in the epidermis, I see a lot of these large lymphocytes that are going into the epidermis. So blue cells, very little cytoplasm, a lot of lymphocytic. We talked about exocytosis when we talk about pleva, or we talked about spongiosis. There tends to be lymphocytes that go into the epidermis, and that is termed as lymphocytic exocytosis. The same phenomenon in a lymphoma is termed as lymphocytic epidermotropism. So the term that you're going to read is epidermotropism, which means something that is attracted towards the epidermis. Tropism means attraction, and then epidermotropism is attraction towards the epidermis. So these lymphocytes are going into the epidermis, so they tend to come from the vessels, from the superficial venous plexus, and then they start infiltrating the epidermis in quite a significant manner. Here you can see there's a lot of lymphocytes that are going into the epidermis. And sometimes they will form like a row at the dermal epidermal junction, and they are called like a row of soldiers. And when you tend to look at these lymphocytes, they are a little bit bigger. People describe their nucleus to be cerebriform. Cerebriform means like it looks like a very convoluted nucleus. You can see that sometimes you may say like this one could be like a cerebriform nucleus, where you see a little bit of a convolution like the cerebrum. Here is another one that looks like a convoluted nucleus. So you can see all of those features. So you can then think that this could be mycosis fungoides, and then we do the stains. So CD3, which is a T cell marker, will be positive. We do the CD4 and the CD8, where the ratio is normally like 4:1. But in mycosis fungoides, we see a lot of CD4 positive cells compared to CD8. And then we do a CD7 that is frequently lost in mycosis fungoides. And we confirm the diagnosis with a gene panel where we want to see a T cell gene rearrangement study, basically positive T cell gene rearrangement study. So if we see all of this, then we know that we are dealing with mycosis fungoides. Case number 90 is another case where we see another proliferation of lymphocytes. So here we see a lot of lymphocytes that are proliferating. You can see all these single lymphocytes that are proliferating. But these are now much bigger. So these are much bigger lymphocytes compared to what you saw in mycosis fungoides. So large lymphocytes, which are also known as sometimes immunoblasts or centroblasts or whatever the right term is, that form this nodular proliferation in the dermis. So again, the first thing I have to figure out is whether this is a T cell or a B cell. So I do a CD3 and a CD20, and this particular one will light up with CD3. So I know that this is a T cell neoplasm because that CD3 is a T cell marker. That will light up. So I know I'm dealing with a T cell neoplasm. So and then I do a CD30, and more than 75% of these large lymphocytes are going to be positive for CD30. So then that tells me I'm either dealing with a lymphomatous papillosis if these lesions are waxing and waning, or it could be an anaplastic large cell lymphoma. Both of them are CD30 positive lymphoproliferative disorders. Another lesion that again shows a lot of lymphocytes in the dermis. I do the CD3 and the CD20. In this one there is more CD20 positive cells. So CD20 is a B cell neoplasm. So once I do the CD20, I know I'm dealing with a B cell neoplasm. Now when I know I'm dealing with a B cell neoplasm, then I look at the histology here. So this is more like these are large follicles here. I can see a large number of follicles here. And the follicle is completely like has a distorted architecture. And there are some large cells here, there are small cells here, so there is a lot of distorted architecture of the follicle. Then I will do my immunostains for the B cell neoplasm. I can do a BCL2, BCL6, MUM1 and all of that. Based on the histological and the cytological and the immunohistochemical features, most likely this is because you can see that this is a follicular pattern, this is a follicular center cell lymphoma. I'm not going to go into the details just because one is the time, and then also like I'm just trying to give you an overview of how to approach these cases basically. Again another lymphoma case here where you can see a lot of lymphoma cells here. So again first the CD3 and the CD20. So this is going to light up with the CD20. So again I know I'm dealing with a B cell neoplasm. This doesn't have the follicular architecture that I saw in the follicular center cell lymphoma. This one has more of a diffuse architecture. And when I go high power, even the cells are much larger here. So I will do again the BCL2, the BCL6 and the MUM1 and all of the markers that are normally done for any kind of B cell neoplasm. This one is going to be positive for BCL2 and MUM1. So all the cells are positive for BCL2 and MUM1 and CD20, which is the B cell marker. And based on this positivity and the histology, I will call it a primary cutaneous diffuse large B cell lymphoma leg type. Moving on to case number 93 here, the lymphoma is more in the fat basically. So I can see that the fat has a lot of associated lymphoid cells. So I can see a lot of associated lymphoid cells here. And the other characteristic feature that I see here is this rimming of the adipocytes with the rimming of the adipocytes with the atypical lymphocytes. So when I see this, I'm dealing with some kind of a subcutaneous panniculitis like T cell lymphoma. And again there is a battery of stains that will help me decide whether this is an alpha beta type or a gamma delta type. Then I can give a diagnosis that this is a subcutaneous panniculitis like T cell lymphoma, whether it is alpha beta, gamma delta, and sometimes even like a NK T cell lymphoma can present like this. So I have to do my battery of immunostains. Without that, it is impossible. I can just say this is a subcutaneous panniculitis like T cell lymphoma most likely, and then do my stains to decide whether it is alpha beta type, gamma delta type, or something else. Case number 94. again proliferation here, but now we are moving away from the lymphomas. The other cell type that you will see, so one is the lymphocytes and the other is the histiocytes. So this is a histiocytic proliferation. So you can see like these large cells here that have this immense large amount of cytoplasm and this round nucleus. So this is more of a histocyte. So this particular lesion tends to have this two-tone cytoplasm. So I can see this two-tone of the cytoplasm here. And there is admixed inflammation here. So I see neutrophils and associated lymphocytes and all of that. So large histiocytic proliferation with this two-tone cytoplasm with admixed lymphocytes and histiocytes, and this is what we classically seen in a reticulohistiocytoma. Reticulohistiocytoma is going to show you the large histiocytes with this two-tone cytoplasm. Some people call it sandpaper like a cytoplasm. So you can like something sandpaper is you rub the sandpaper and this rose color or sandpaper comes when you rub that sandpaper. So based on that, this is a reticulohistiocytoma. We are coming to the end. 5 more cases. On a 54-year-old hyponatremia lesion on the eyelid. So again, we are still with the histiocytic neoplasm. So this is another. You can see like these are large macrophages. Again, this has this xanthoma-like. So this is a xanthomatic lesion where you see this clearing of the cytoplasm and then the pycnotic nucleus. So you are dealing with a xanthomatic lesion. So this is on the eyelid. It is composed mostly of this xanthoma cells. So based on if you see mostly xanthoma cells, this is a xanthelasma. If I start seeing a lot of lymphocytes, neutrophils, fibrosis, then I can start thinking of the tendinous, the fibrinous xanthomas, the plain xanthomas. But lesions on the eyelid that show a lot of xanthoma-like cells collection, then that is a xanthelasma. 96-year-old. This is now a lesion on the scalp, but this is positive for markers. These are markers for a renal cell carcinoma. PAX8 and CA9 and SOX10. This is actually a metastatic renal cell carcinoma, which shows a lot of features that we saw in sebaceous carcinoma. And the importance is like we talked about the cytoplasm that has the compartmentalization in the SIBO. Now, if you look at this one also is clear, but does not have the compartmentalization. So that tells you that this is not a SIBO site. This is something different. This is a collection of these clear cells, and they tend to have a lot of these vascular structures. So you see a lot of admixed vascular structures here. When you see a collection of these clear cells with a lot of vascular structures, then you have to think of a metastatic renal cell carcinoma. Then you do these stains here, PAX8, CA9 and SOX10, and those will be positive. And then you know you are dealing with a metastatic renal cell carcinoma. Case number 97, younger patient. This is a proliferation of now. You can see like these cells here. Let's go and look at these individual cells. So if you look at these cells, here, they have this fried egg-like kind of appearance. So this large amount of cytoplasm with a very central kind of nucleus, and this is known as a fried egg appearance. And a fried egg appearance is mast cells. So this is a collection of mast cells. So that is the other cells that you can sometimes see in the dermis. Proliferation of mast cells can also occur. So this is a collection of mast cells in the dermis. So it could be a mastocytoma. But given the history that this is a 6-year-old patient with multiple reddish brown macules, this is urticaria pigmentosa. So urticaria pigmentosa tends to show you a collection of mast cells in the dermis. Case number 98. Now we are seeing some kind of a discoloration of the dermis because the patient was applying some cream that contained hydroquinone. Hydroquinone can cause destruction of the homogentic acid, and this gets deposited in the dermis. And this is deposition of homogentic acid in the dermis. In the books, they are described as banana bodies in the dermis. So this is ochronosis, where you see this homogentic acid deposited in the dermis because the patient applied hydroquinone on the skin.
Case number 99. Bluish gray discoloration on the face. And the patient has been seeing this for multiple years. So this is like a very normal looking skin here. Nothing in the epidermis, nothing at the junction, nothing in the dermis. So this is almost like a normal color, normal appearing histology. But then there was this gradual diffuse bluish gray discoloration of the face. So what is causing the discoloration? So when we go high power, we start looking at these eccrine glands. You can see there is a lining here that is pigmented here. There's a lining here that is pigmented here. There's a lining. So this is deposition of silver that occurs around the eccrine glands. It can also sometimes occur across the, and this deposition of silver is what is giving the bluish gray discoloration, and that is what is termed as argyria basically. So this is a case of argyria. And then the last case, rapidly growing lesion, and we can forget this one because this one is a very rare diagnosis. I kept it as a bonus case because this is a very new described lesion. In the WHO came up with a new skin book just recently last year. And one of the new lesions that was described is a cutaneous nut carcinoma. That tends to look like a very basaloid and a squamoid proliferation. But has a lot of ATP and has admixed ducts. And then this is positive for nut protein. So this is a very new described lesion, but the 99 cases that we talked about were the common lesions. This is a very new described entity in the WHO Blue Book basically. So that should be the end of today's topic basically. Sorry, I went a little bit over basically.
Thank you very much, Professor Rajendra Singh. I know you have put in a lot of effort for this in terms of the psychological support that you should have been given at the time when you really had problems. So we just cannot thank you for what you have done for us. More than saying thank you. All of us will give you a big round of applause.
Thank you very much. And if you have any questions we were talking about skin pathology, so my email is skinpathology@gmail.com. If you have any questions, you can send me an email at skinpathology@gmail.com, and I can then respond back to your question.
We would most certainly do that. And as a mark of appreciation for all that you have done for us, we have a plaque.
Thank you very much.
We have a gold medal for you.
Thank you. Yeah, I wish I could be there, but next time, it was not destined to be there.
And a certificate also. You are destined to get it in the near future. I am there with you next month. And I'll carry this for you, Professor Rajendra. My good friend, my very good friend. Thank you very much.
Thanks a lot.
Right. So
thank you to the audience for being patient and staying for so long.
They have been gifted to hear you for such a long time, for 4 hours put together. They are very lucky. So shall we de-link?
Yep, thank you very much.
And there is an announcement for the rest of you here. Within another 15 minutes we can go for dinner. Please stay back for dinner. Have your dinner. And then meet you tomorrow around 8:30 a.m. You can announce that again, please.
Sincere gratitude to Professor Rajendra Singh sir for meticulously collecting and presenting these 100 cases to make dermatopathology relatively easy. I'm sure that all the young minds and experienced consultants now have a lot of clarity on the subject. Thank you, sir. I would also like to thank Professor Jacob Thomas, sir, and Dr. Dawn Ambrose, ma'am, for chairing this long and interesting session and making it more interactive. That marks the end of this workshop. I request everyone to please collect their workshop certificates and join us for dinner at 7. We'll meet tomorrow at 8:30 a.m. sharp for the commencing day of the conference. Thank you and have a nice day.
You all can collect the workshop certificates where the registration was done at the registration desk. Same place.